Dr. Suresh, you can stop screen share. We'll begin. Dr. Suresh, could you please stop screen share?
Can you see my screen?
Yeah, we can see your screen, sir. Could just stop it, we'll begin.
Oh, okay. Stop it. Okay. Okay, sorry.
Right. Namaskaram, everyone, and welcome to IIP Twin Cities branch Symposium on Pediatric Gastroenterology. I hope you're all doing well. IIP TCB is conducting this symposium every month on one specialty, and it's our pleasure that we've had specialists from across the country and this time even across the world joining us and sharing their expertise and insights on very complex and interesting subjects. I seek your support for the upcoming IIP PATS TCB Annual Pedicon 2022, which is being held by IIP TCB and PATS together. It promises to be an experience like never before, something that you'll cherish all life. Please register for the conference, and I'm sure you'll have a memorable experience. We also have a few central IIP workshops coming up on pediatric gastroenterology, developmental neurology, and pediatric endocrinology. These are all physical workshops, and I request you to please join us at the locations in Hyderabad. And I'm sure you'll have a wonderful time from listening from the experts on these in these workshops. I also take this opportunity to request all of you to please exercise your right to vote. The IIP elections start today, and beginning 10 a.m. from today, we'll have online elections for central IIP posts from the president till the central IIP EP members of Telangana state. And as members of the association, it is our responsibility to ensure that we exercise our right to vote and elect the persons by participating in huge numbers. With these words, I'll now hand it over to our president, Dr. Sunkoj Bhaskar sir, for his remarks, and then we quickly move on to the academics. Over to you, Bhaskar sir.
Yeah, thank you, Dr. Harris. Thank you. Distinguished faculty members and as well distinguished participants. Good morning, you all, and good evening to those who are from US. And I welcome you all to this 10th IIP Twin Cities branch monthly virtual symposium. We are very proud, we the executive body of IIP Twin Cities branch, we are proud to say that we had been doing it every month, one symposium on one subspecialty. We had done 9 subspecialty symposia, and this is the 10th one. Not only this, IIP Twin Cities branch is happy to inform to some of you who are not familiar with IIP TCB activities. Every month we have 3 programs. One is IIP TCB monthly symposium, and another is IIP TCB PG clinics every month, wherein one resident will be presenting a long case, and the lead discussants will be the experts, the professors or professors emeriti. Third program, we have IIP TCB clinical meeting, wherein we will be presenting 4 interesting cases every month from various hospitals. And we have been successfully doing all these programs virtually, and all of them are recorded on YouTube. Whenever you find time, you can go through them. We are able to do it because of various reasons. And first and foremost, we have so many pediatric hospitals in Hyderabad, probably one of the few cities having maximum number of pediatric hospitals with quality care and with excellent faculty, excellent academic body. Otherwise, we could not have done so many activities. If you take Dr. Ramesh Srinivasan here, Dr. Prashant here, they contribute so much to our academy, teaching or clinical cases or participating actively in conferences. So With these few remarks, I sincerely thank the distinguished faculty members, Dr. Ramesh, special thanks to Dr. Ramesh Srinivasan, who had scripted this and coordinated this entire program and had helped me a lot in making this program a reality. My special thanks to Dr. Prashant Bachna. He's, all of you know, he's a pediatric gastro and hepatologist, presently at Rainbow Hospital. And he does a lot of works in liver transplant. And he has a lot of future plans about liver transplants. We have with us Dr. Sirish Kumar. He's a pediatric gastroenterologist as well, hepatologist. Presently, he is in Oklahoma University Hospital. Thank you, Dr. Sirish, despite being it's a late evening for you joining us. And Saturday is supposed to be for your family. And my special thanks to Dr. Jagdish Menon. I was going through his academic laurels. They're really very attractive. He did all his MD, DM from PGH Chandigarh. Then he's working in a prestigious Raleigh Institute of Medical Sciences. And our youngsters, our Dr. VVS Chandrasekharan, I should tell a few words about him. He's the finest of the finest surgeons, pediatric surgeons available in Hyderabad, particularly his endoscopic pediatric neurosurgeries and as well pediatric surgery by itself. We are lucky to have him because he's a versatile person. He's a good speaker, good academician, a good surgeon, and as well a good classical singer. And we have with us Dr. Pandu Chauhan, a rising star in pediatric gastro from Hyderabad. He did his MD from AIMS, Delhi. I hope I had covered all the people. So with these few remarks, I request our program coordinator, Dr. Ramesh Srinivasan. I think he's the first or one of the few who had brought in revolutionary changes in the management of pediatric gastro cases. He's a consultant at our prestigious Apollo Hospital, Jubilee Hills. He's well trained in UK, and before that he was in he did his MD from AIMS. Am I right, sir? Okay, so
Chandigarh, sir. I'm senior
PG.
of Jagdish by many years. I'm from Chandigarh. And then the UK, I'm a consultant in Liverpool all the way, then back here. I trained in hepatology at King's and Leeds. Then I was a consultant in UK for around 3 years before I came back here. So I do most gastroenterology, hepatology. We have a transplant unit also in Apollo. So hands in every place.
Yeah. So nice. We have luminaries. From Hyderabad, from Chennai, from US. It's really amazing to see you all. Now I request Dr. Ramesh Srinivasan to take over and conduct the academic activity. Over to you.
Thank you so much, Bhaskar sir, for the introduction. And like what you said, we have a lot of very distinguished speakers, very accomplished gastroenterologists and hepatologists, rising stars in this particular field who will be the leaders in the time to come. So we first are going to actually listen to Dr. Sirish about acute liver failure in pediatrics. Pediatric acute liver failure basically has actually changed, the management has changed, and our outlook towards pediatric acute liver failure management and transplantation has also been actually sort of such a revolutionary change over the last few years. So what I would do is I basically would request Dr. Sirish to start off his presentation. Thank you.
So thank you everyone. Let me share my screen and then. You all can see my screen? Can you see my screen? Okay. So thank you everyone for attending this session. I would like to thank IIP Twin Cities branch organizers, especially President Dr. Bhaskar Sangoj, Dr. Sri Krishna, Secretary, and Dr. Vamshi, Treasurer, for this kind invitation. It is an honor to be here and to do this talk. And my topic today is update on pediatric acute liver failure. So objectives for my talk today are define pediatric acute liver failure. I'm sure most of the audience in this group knows the definition for pediatric acute liver failure. Understand age-dependent etiologies for acute liver failure, both in India and here, and understand management of acute liver failure. And the main update I have in pediatric acute liver failure is understand impact of immune dysregulation and novel opportunities for intervention in pediatric acute liver failure, which are really emerging here in the United States. So I'll start off with a case. This is the case from our institute here a couple of years ago, and this case would lead to the discussion of the new updates in pediatric acute liver failure. As you can see here in this case, we have an 11-year-old Hispanic male who presented with acute jaundice, and his labs, as you can see here, he has significantly high INR, which is a synthetic function, and he got 3 doses of vitamin K, which was not corrected. Then he also has liver dysfunction in the form of hepatitic pattern and cholestatic pattern, but predominantly cholestatic pattern of liver injury with high direct bilirubin. And then on exam, he did not have any encephalopathy. So next, we did a transjugular liver biopsy on him, which showed his biopsy showed massive parenchymal necrosis up to 70% of the liver, and remaining 30% of the intact hepatic parenchyma showed marked portal, lobular, venular, and dactylar lymphocytic infiltrates. And we did extensive workup on this kid, labs, imaging to determine causes of acute liver failure, and everything has come negative. And I'll show you what all the workup we did in this age group. So right now we are at a place where the cause is not known, very frustrating, indeterminate. So I will use, throughout my talk today, I'll use the indeterminate cause of acute liver failure a few times, and I want to stress on that. So pediatric acute liver failure is a syndrome rare syndrome in children, but it can cause significant mortality and morbidity. So how you define pediatric acute liver failure? This is the definition for pediatric acute liver failure support group. This acute liver failure support group in US was formed. It's a multi-center collaboration trial run between 1999 and 2015 across 25 states in the United States. And they recruited more than 1,100 kids. It's an NIH UN grant, which was very well done. As you can see, these are the 3 criteria they included in acute liver failure. Historically, children were assigned an acute liver failure diagnosis based upon adult definition that included hepatic encephalopathy. As we all pediatricians, we all know how challenging it is to assess hepatic encephalopathy in children, especially infants. So HALF study group utilized these consensus entry criteria for their longitudinal study with less emphasis on hepatic encephalopathy. As you can see here, to meet this criteria of acute liver failure, they need 3 components. One of them is acute onset of liver disease without evidence of chronic liver disease, biochemical evidence of severe liver injury, coagulation which is not corrected by vitamin K in the form of prothrombin time more than or equal to 15 seconds, which is INR more than or equal to 1.5 if you have hepatic encephalopathy. If there is no hepatic encephalopathy, INR more than 2. So these are the 3 criteria for acute liver failure, which were proposed in pediatric acute liver failure support group here. And the patient I showed you, our patient, met most of the criteria with his liver dysfunction and then INR 2.4 and did not correct with vitamin K. So acute and chronic liver failure is completely a different game. This is a syndrome in children with chronic liver disease with or without previously diagnosed cirrhosis, characterized by acute hepatic decompensation, which results in liver failure, and 1 or more extrahepatic organ failures. And this is associated with significant or increased mortality, especially 3-month mortality. So both are different. And then there is a lot of heterogeneous definitions for acute and chronic liver failure, unlike the acute liver failure. Europeans, Asians, and Americans, they have different criteria to be an acute and chronic liver failure. So some people even classify acute liver failure into 3 subphenotypes, as you can see here, based on time from jaundice to encephalopathy. It can be hyperacute, acute, or subacute. It's hyperacute if the time from jaundice to encephalopathy is less than 1 week, which is associated with severe coagulopathy and very high degree of intracranial hypertension. It can be subacute if it's over a period of 4 to 12 weeks with less coagulopathy and less degree of intracranial hypertension. If you look at worldwide causes of acute liver failure, this is across all age groups. This paper was published in New England Journal of Medicine. It's a slightly old paper, but it gives you a good overview. As you can see in India, looks like infectious hepatitis are the common causes of acute liver failure, up to 60%. None actually acetaminophen in this paper. Unknown, again, I'm stressing here, unknown is still 30%. And if you move across to US, acetaminophen acute liver failure is close to 40%. And then infectious hepatitis is very few, like 5 to 6%, and unknown is 20%. So this is very important. And if you come to pediatrics, which is the crux of this talk, and this is a paper I pulled up from Liver International in 2017. As you can see, profile and outcome of 109 kids with pediatric acute liver failure in specialized pediatric liver unit in Delhi. As you can see here, viral infections are the predominant causes of acute liver failure in children, predominantly being hepatitis A. Then the other viruses are hepatitis E, parvo, EBV, varicella viruses. And then the other causes are like, again, indeterminate, where the cause was not established. Actually, this surprised me. If you look at the indeterminate, 13% of them died in the indeterminate, which is like 80% of them died in indeterminate causes. Again, I'm stressing there, and I'll tell you why. And then the other causes are like drug-induced liver injury, metabolic liver diseases. Also, few of them, like majority of them died. The causes were like galactosemia, tyrosinemia, fatty acid oxidation defects, mitochondrial urea cycle disorders, and others. In the others, which was fewer HLH, the hepatic venous outflow tract, now what is called sinusoidal obstruction syndrome. So coming to US here, if you look at causes of acute liver failure here, if you look at less than 1 year, and if you break them down into neonates, 4 to 8 weeks, and 9 weeks to less than 1 year, if you look at it in neonates, viral hepatitis, this 30 number is N, and in brackets its percentage is quarter of them are from viral hepatitis, and then 16% of them are from metabolic, and then 16% of them are from neonatal iron storage disease, which is also called gestational autoimmune liver disease. And then look at the indeterminate causes are like 30%. So if we move up slightly high, 4 to 8 weeks, again, metabolic are predominant. Next is neonatal iron storage disorders. Again, 40% of them are indeterminate. And if you continue to move up, metabolic 20%, and then indeterminate is 50%. Metabolic liver disease in the pediatric acute liver failure study group constituted around 28 to 36%. And common culprits in infants and children for metabolic causes here in the US were galactosemia, tyrosinemia, Niemann-Pick, mitochondrial hepatopathies, and urea cycle disorders. So I just want to highlight here, indeterminate causes of acute liver failure was significantly high. And then again, if you go up on the age group 1 to 5 years, 6 to 10, and more than 10, again, you can see here, autoimmune starts coming up into the picture after 1 year of age. Viral hepatitis is still there, and some metabolic, and then still predominantly indeterminate. And then after 5 years, we start encouraging or entertaining Wilson's disease as metabolic causes for acute liver failure, and then autoimmune, some viral, and then more than 10 years, you'll start seeing acetaminophen acute liver failure, and then metabolic, autoimmune, viral hepatitis, and some again indeterminate. If you look at it, significantly high number. So definitely we want to know the etiology of the acute liver failure because really it helps the prognosis. So if you look at spontaneous recovery on the right side, ischemic hepatitis, also known as hypoxic ischemic liver injury, HILI, has a high chances of spontaneous recovery. Acetaminophen injection also has high chances of recovery. Herpes infection, hepatitis causes have high chances of spontaneous recovery. But in the middle, autoimmune hepatitis, idiosyncratic drug reactions, and indeterminate acute liver failure might need liver transplant. And if you go to the left of the spectrum, mitochondrial, especially some defects like POLG, DGUOK, those are the ones which are multi-system disorders. They may have unlikely benefit from transplant or poor survival, but that thing is changing now. They're seeing good outcomes in the recent data. So how do you approach a kid with pediatric, like acute liver failure? History, if you look at the history, in the history, you ask for infectious history, recent travels, known sick contacts, any injection, over-the-counter medications, herbal supplements, illicit drug consumption, mostly here in US, wild mushrooms, exposure to household or industrial chemicals. And autoimmune causes like family history of autoimmune disease, metabolic causes like pre-existing developmental delay, family history of liver disease, consanguinity, recurrent miscarriages, and episodes of any altered mental status or confusion. So history is key. On exam, in addition to encephalopathy, you look for any features of dysmorphic features, hepatosplenomegaly, especially splenomegaly, to suggest any signs of portal hypertension, ascites, clubbing, rickets, and then xanthomas, varices, abdominal varices, or spiral angiomas, or peripheral edema. So these are the physical exam findings, especially you're looking for any evidence of chronic liver disease to see if that kid ahead is like an acute and chronic or acute liver failure. So approach lab testing is very extensive. Again, especially if you're dealing with the pediatric infants or young infants, it's too expensive to draw so many labs. But the initial diagnostic workup is all the patients would get a complete blood count with differential complete metabolic profile, GGT, PTINR, blood type, and screen, especially if you're considering listing them for transplant, and also transfusion needs, acetaminophen level, toxic screens in the blood and urine, ammonia, infectious hepatitis workup, hepatitis A, B, C, D, A, B, C, and E, Doppler with ultrasound, abdominal ultrasound, and blood culture. And coming to additional workup based on the age, you can see if it's less than 3 months, you look for lactate pyruvate to look for as a screening for mitochondrial diseases, plasma amino acids, organic acids in the urine, or for urea cycle disorders, urine succinylacetone for tyrosinemia, plasma cell carnitine profile for fatty acid oxidation defect. Alpha-1 antitrypsin level and phenotype would not present with acute liver failure that I know of, but definitely it alters the course of other liver diseases which present with acute liver failure if you're a carrier or if you're affected. And again, iron, TIBC, and ferritin, especially in less than 3 months neonates, helps us with the gestational autoimmune liver diseases, viral cultures, respiratory, urine, and stool, HSV, adeno, HHV6, entro, and other viral serology, drug history. And here we confirm the newborn screen results, especially ruling out some of the metabolic disorders, and soluble interleukin-2 receptor levels and triglyceride levels, especially if you're thinking of HLH. And then in 3 months to 16 years, again, similar workup, especially you start entertaining here autoimmune hepatitis, as I mentioned before, you do the immunoglobulin levels, total IgG, ANA, smooth muscle antibody, anti-liver kidney microsomal antibodies, and then also Wilson's copper, serum copper, ceruloplasmin, and 24-hour urine copper, in addition to the similar workup which you do in less than 3 months. So getting the history exam and then some workup, especially general workup and age-specific workup to get to the etiology is the key. And then once, how do you manage is, if any kid meets the criteria for pediatric acute liver failure, as I mentioned in my initial presentation with elevated liver enzymes, no history of chronic liver disease in the past, or and then synthetic function INR being high, and then you give vitamin K and you cannot correct it. So if they're meeting, transfer the kid to an experienced pediatric liver transplant center. Then at that time, you start assessing for any signs of hepatic encephalopathy, cardiovascular instability, hypoglycemia, or multi-organ dysfunction like renal injury or respiratory failure. If you see any of those signs, then transfer them to ICU and implement or continue supportive care. And while you are doing the diagnostic investigations and treatment, which is very few, and then if they're stable, then you transfer them to medical floor for continued medical management. So this is the approach we kind of pretty much follow here also. And so coming to the complications, what we see in the acute liver failure, coagulopathy is the important thing which we see in the acute liver failure, and we define acute liver failure based on INR. As I mentioned in my initial presentation, you will see elevated INR, decreased levels of factor 5 and 7, decreased fibrinogen, and you will see the thing to remember is clinically significant spontaneous bleeding is very uncommon in acute liver failure, less than 10%. So we truly discourage correcting the INR with FFP or cryo or anything like that. The only thing recommended is vitamin K, which we administer IV to make sure the kid is getting well in an ICU setting for 3 to 5 days. And then please remember that complete correction often is not possible. And then as again, I want to stress this, prophylactic FFP and platelets are not recommended unless there is signs of any active bleeding or any invasive procedures like arterial line, central line, intubations are performed in the ICU. And then what is the targets you treat is you want to bring down the INR to less than 1.5, fibrinogen level to more than 100, and platelet count more than 75. Again, FFP and recombinant factor 7 are not advised. In my previous center where I did my training at Emory, in kids with acute liver failure, especially with raised intracranial hypertension, we used to use bolts for intracranial pressure monitoring. Those are the kids used to get recombinant factor 7 before inserting, neurosurgeons put in bolts. And then H2 blockers or proton pump inhibitors recommended to prevent GI bleeding. And again, as I mentioned, spontaneous or clinically significant bleeding is very uncommon, less than 10%. And then our ICUs here use TEG to characterize coagulopathy. TEG is thromboelastography, which measures all phases of hemostasis in whole blood. As you can see, clot formation, it's like clot kinetics. Clot formation and fibrinolysis are being measured. And then it measures the initial fibrin formation, rate of clot formation, quality, strength of clot, and clot lysis. And again, because of the overall homeostasis is normal or preserved by severe compensatory mechanisms. If you think like that, in acute liver failure, both coagulant factors like factor 5, factor 7, factor 10, and then anticoagulant factors like protein C, antithrombin 3, and protein S, both are reduced. So you maintain the hemostasis overall. And then again, you want to know what is the INR is your prognosticating factor. So you want to know what is the natural synthetic function of the liver. So that really helps. That's the other reason you don't want to correct the coagulopathy aggressively. And then again, if you give FFP and blood products, you're increasing the risk of volume overload and then increased intracranial pressure and further complications. So coming to the intracranial pressure, increased intracranial pressure, which manifests clinically as hepatic encephalopathy. This is the most lethal and least understood complication of acute liver failure. You do physical exam, EEG, and CT scan, and it can be multifactorial based on hyperammonemia measured in the arterial blood associated with increased levels of glutamine within astrocytes, results in cell swelling, brain edema, and then hyperammonemia alone does not predict intracranial hypertension. Also, increased cerebral blood flow facilitates water movement down, altered osmotic gradients, and then systemic inflammatory response may also play a central role. Again, this is a very busy table, how you assess encephalopathy. I don't want to go in As you can see, it's a different ways you assess encephalopathy in kids less than 4 years and more than 4 years. There are different staging, stage 1, 2, 3, 4, and stage 3, 4 are severe ones, and most of the time they need intubation to protect the airway. And how do you manage in general increased intracranial pressure is by in the ICU, quiet surroundings, minimal stimulation, elevating the head end of the bed to 30 degrees, neutral position, maintain the PCO2 between 30 to 40, euthermia, if needed, mannitol, if any concerns of increased intracranial pressure, maintain the sodium between 145 and 155, and intracranial pressure should be less than 20, maintain the cerebral perfusion pressure more than 50, in general, and then, as I mentioned, stage 3 and 4 encephalopathy will require mechanical ventilation. So the other things for hepatic encephalopathy is consider reducing the protein intake to 1 milligram per kilo, and lactulose is used because lactulose creates acid intraluminal environment which favors conversion of ammonia produced by gut microbiome to ammonium that decreases intestinal absorption, and rifaximin to alter intestinal microbiome and decrease ammonia production, and extracorporeal liver support devices are also used like MAS, plasmapheresis, and CRRT to bring the ammonia levels down. And in general, sedation-wise, avoid benzodiazepines, and again, obviously avoid acetaminophen. Fentanyl is the preferred opiate, and discuss your plans thoroughly with the ICU team, and medical restraints and decreased stimulation is the key. Infections are the common cause of death, especially like pneumonia, UTI, blood infections like gram-positive cocci, gram-negative rods, fungi. So our institute, we use empirical antifungal coverage for these acute liver failure kids. And this is a controversy regarding empirical antibiotic coverage is recommended for acute liver failure patients listed for transplant, but some centers use it, some centers don't use this empirical antibiotic coverage. Nutrition is very key. Enteral if possible in early stages, otherwise TPN, we start parental nutrition quickly, and the protein restriction is 0.5 to 1 gram per kilo. And glucose infusion, sometimes you need high rates of GIR, glucose infusion rate, to maintain euglycemia. No restriction on fat or interlipid unless there is concern of fatty acid oxidation defect. And then coming to circulatory dysfunction, maintain age-appropriate blood pressures. And as you know, this in the acute liver failure, there are a lot of cytokines which are not cleared, hepatotoxic cytokines. They can cause vasodilatation and circulatory failure, so they need vasopressors, especially norepinephrine. And then the goal is to keep the cerebral perfusion pressure, as I mentioned, more than 50. And then renal electrolytes and fluid management, if there is any concerns for decreased creatinine clearance and urine output, consider renal replacement therapy. And then, maintain glucose level between 90 and 120, maintain sodium level between 145 and 155 I mentioned. And then hypophosphatemia is common and should be treated to keep the serum levels more than 3 milligrams per deciliter. And then other therapies like N-acetylcysteine, there's big, in the PALF study, they looked at use of N-acetylcysteine as in non-acetaminophen acute liver failures, but the data, these results, the data is not that great, and these results do not support broad use of NAC in non-acetaminophen induced pediatric acute liver failure. And then liver assist devices have fallen short, so these are not routinely recommended like MARS. The only thing these can be used is as like bridge to transplant. And in general, avoid benzodiazepines, ICP precautions plus euthermia, maintain sodium, maintain COD levels between 30 to 40, do not correct coagulopathy unless invasive procedures, empirical antifungal coverage, nutrition, parental nutrition, start early, maintain age-appropriate blood pressures. If there is any concerns for renal dysfunction or fluid overload, CPVH is used. If you look at etiology, are there any specific therapies for patients with acute failure? I can think of only these few instances, acetaminophen, where you use N-acetylcysteine as the treatment, herpes simplex viral infection, especially in the neonates and young infants. Acyclovir is used. CMV infection, which is not that common, ganciclovir used. If you have autoimmune hepatitis, we use methylprednisolone as IV for acute liver failure. So contraindications to transplantation is if you have a kid who has a very low cerebral perfusion pressure, less than 40 for more than 2 hours, and uncontrolled intracranial pressures, and then uncontrolled infection or sepsis, severe intracranial hemorrhage, progressive or end-stage extrahepatic disease, systemic disease not correctable, like if you're thinking about mitochondrial and if you're concerned that there could be a neurological form of this mitochondrial disorder, those are the other things which are contraindicated for orthotopic liver transplant. So coming to the, again, the recent update I was mentioning, as you can see, these pie charts, as you can see, as I mentioned in my causes of pediatric acute liver failure, both in India and here, there's pretty much up to the pediatric acute liver study group did the study in 3 phases, phase 1 to 2 and phase 3. If you look at the causes of indeterminate failure, it was 48%. Then they started introducing implementing standardized EMR-based age-specific order sets. Like as I showed you, this age group less than 3 months, 3 months to 1 year, these are all the labs needs to be done. When they did that, this indeterminate has dropped from 48 to 31%. So if you do the proper workup, you can still identify a cause. But unfortunately, still 31% of them was indeterminate. So that's the big concern, what to do with this indeterminate. And again, there's more data, and I've showed you from India also. There's a lot of mortality in the indeterminate group. So what is the cause? And there have been looking into this indeterminate pediatric acute liver failure, which is up to 30, some cases 50%, fits with features of like hyperinflation syndrome, HLH, and macrophage activation syndrome. So it is thought to be an imbalance between pro and anti-inflammatory factors. So mechanisms driving injury in indeterminate pediatric acute liver failure have been postulated to occur these secondary to overzealous inflammatory response and immune dysregulation. So the PALF group has done further look into this indeterminate acute liver failure, and they identified some biomarkers of immune activation for indeterminate. As you can see here, you can see increased CD8 and T infiltrates, increased porphyrin, predominant CD8 T cells, and then other markers, especially soluble interleukin-2 alpha levels. And again, in this immunohistochemistry from the indeterminate acute liver failure and then known cause of acute liver failure, as you can see, the CD8 level markers and CD103, which is the marker of one of the memory cells, as you can see, these markers are very high, suggesting there is some target.
Suresh, this is Dr. Ramesh Srinivasan. I think we are getting a little close to the time.
Okay, I will wrap up in one slide. Okay, so this initiated the trial, big trial in the US. It's called a Triumph trial, where they're using high-dose methylprednisolone, ATG, and placebo, as you can see, to look at the outcomes from this trial. So, and again, this has shown significant benefits. Even in our case, when we did use salmeterol high dose, it didn't help. Then we used ATG, equine ATG for 7 days. It got complete excellent clinical and biochemical response. We followed with tacrolimus. So my thing is, this indeterminate etiology, we have to accept this. And then there is immune dysregulation thing to this indeterminate etiology. So, and there are treatment options, and then there are randomized control trials in US ongoing. So in conclusion, pediatric acute liver failure is a devastating disease, and early recognition is important. And biochemical evidence of liver dysfunction and coagulopathy, focused and rapid assessment for etiology, excellent supportive therapy with multidisciplinary approach, early communication, and again, ongoing trials expected to provide valuable insights into pathophysiology mechanism driving inflammation in indeterminate HALF and whether intervention can also reverse. Actually, I've seen shown in our case, and we are seeing good data with reversal of the inflammation and then outcomes. Thank you very much, and I'm happy to take questions later.
Thank you so much, Dr. Sirish. That was a wonderful and very succinct presentation on pediatric acute liver failure. You basically brought out some very important facts. Let it be India or let it be the West, the indeterminate cause of hepatitis or acute liver failure is still there, 30 to 50% in different series. Am I audible? Am I audible, Dr. Sirish?
Yes, yes, yes.
Yeah. So the indeterminate causes, earlier times we used to call it a non-ATV hepatitis, and rightly pointed out, the mortality in the indeterminate group seems to be higher compared to the other groups. What was that? That's what your experience also showed, yeah?
Yes, yes.
Now,
so indeterminate causes are pretty much 30 to 50%, depending on where you look at, especially in infant, like 1 to 4 years, it's even higher, 50 to 60%.
Yes, absolutely. And like what you pointed out, in India, still infection seems to be the most important cause of acute liver failure. Bringing to attention the paper by Julia Venden and others, which they've actually looked at the whole world's cause of pediatric acute liver failure and acute liver failure in general. They disproportionately point out hepatitis E being fairly very high in India. That's not the case, actually. We don't know. That is one particular thing. We have a lot of hepatitis A here. We do have pockets of hepatitis E, and our indeterminate rates may be as close to 50%, like what you have actually pointed out, because the workup also is insufficient in some cases. So that is true. And one other thing, which is a very important message from today's meeting, is coagulation is actually a very important kind of marker. It gives the latest and the best indicator of how the liver is, and chasing the coagulation is actually very important for us to make plans about how to look after children with liver failure. So sometimes clotting gets missed as part of the initial assessment of liver failure, but that is very important. Yeah.
Yes, I think the one thing I want to convey is indeterminate, and the mortality is very high in indeterminate cause of liver failure. That's the other thing I want to point out is, and there are treatment options, immunosuppression therapies.
Yes, yes. So you'll be staying for the panel discussion, Dr. Sirish, later?
Yes, yes, yes. I'll be available. Yeah.
Sure. So thank you so much for joining us from Oklahoma so late in the night. We're so thankful to you for actually giving us your valuable insights on pediatric acute liver failure. Thank you so much.
Thank you. It's my pleasure. Yeah.
Thank you. Hello? So you stop screen sharing now. The video is not on. Yeah, so back on. So next, we are basically sort of having Dr. Pandu Chauhan, who actually is with KIMS Hospitals in Kondapur in Hyderabad. He is a pediatric gastroenterologist who basically has trained in AIMS, and he basically has started doing pediatric gastroenterology services at KIMS Hospital. And he is going to speak to us about malabsorption, approach to malabsorption, investigations, and management. So Dr. Pandu Chauhan, please. Yeah, your screen is visible to us. You can go to slide share.
Yes, sir. Okay.
Yes, yeah, we are able to see your slides. Yes, please start.
Sir, am I audible, sir?
Yes, yes, you're audible. I'm able to hear you. Yes, please tell.
So today my topic is approach to pediatric malabsorption. So the outline of today's discussion is definition of malabsorption and maldigestion, prevalence and etiological spectrum, and pathophysiology of the malabsorption, and when to suspect, and diagnostic consideration, investigations, and management. So when it's come to the diagnosis, it is inability of the gastrointestinal tract to adequately absorb nutrients, which occurs due to defect in any level in the multi-step sequential process of digestion absorption, which leads to compromised nutrition, growth, and other systemic abnormality. Maldigestion is a defective intraluminal hydrolysis of nutrients, which is most of the time it is due to the pancreatic, exocrine pancreatic insufficiency. So as we know that digestion and absorption is a multi-step sequential process. In the luminal phase, there will be mixing, solubilization, hydrolysis with the help of bowel motility as well as gastric juice, bile and pancreatic juice. In mucosal phase, we have breast bladder enzymes and absorption with the help of either passive diffusion or active transport, and formation of resynthesis of triglycerides in the enterocytes, and followed by post-absorptive phase, transport into the lymphatics and blood. And the defect at any level can lead to malabsorption. So now let us look at the prevalence. It is one study from Northern India done around 30 years ago. So when we look at these children, this study enrolled children less than 15 years. The number was 137. When we look, the children less than 2 years was 45, and more than 2 years were 55%. So when you look at the overall cause of the malabsorption, it is a protracted diarrhea, 33%, followed by celiac, followed by infestations. When we look at the age appropriate, so in children less than 2 years of age, it is protracted diarrhea, followed by cow milk protein intolerance and other. When it's come to the children more than 2 years, it is celiac disease, followed by parasitic infestation. This helps us in the appropriate evaluation and management of the children with malabsorption. So let us look at the pathophysiology of digestion absorption. Due to the advent of the next generation sequencing and advanced investigation in the last 2 to 3 decades, we discovered that there are many disorders due to enterocyte transport and uptake defects. Now, when you look at the carbohydrate absorption, digestion absorption, it begins in the oral cavity with the help of lingual amylase. Then it proceeds with the help of gastric amylase and pancreatic amylase. So any abnormality in the mixing, motility or pancreatic amylase can lead to luminal malabsorption of the carbohydrates. Next, after the luminal dehydrolysis, we get the tripeptides and polypeptides. These polypeptides and tripeptides are further undergo digestion or hydrolysis with the help of membrane enzymes. These are the 4 disaccharidases present in the breast bladder membrane of the enterocytes. This is lactase, maltase, sucrase, isomaltase, and trehalase. So in most commonly in clinical practice, we see lactase deficiency, where the most common is secondary lactase deficiency, and the primary and congenital are rare. The end products of the carbohydrate digestion are glucose, galactose, fructose, and trehalose. Glucose and galactose are taken up by the enterocytes with the help of sodium-dependent glucose transporter 1 or facilitated glucose transporter GLUT2. And galactose also same, which follows the path of glucose. And fructose is taken up by the GLUT5, and trehalose is taken up by the GLUT2. And GLUT2 is also present in the basolateral membrane of the enterocytes. With all these monosaccharides are transported from the enterocytes into the lymph with the help of GLUT2. So this is the schematic diagram showing this similar the carbohydrate membrane enzyme deficiencies and transporter defect. So deficiency of the lactase, which is the breast bladder enzymes, can lead to lactose intolerance, and sucrose isomaltase, which is another breast bladder enzyme, can lead to malabsorption of the starch. When it's come to the transporter defect, the glucose and galactose are taken up by the enterocyte with the help of SGLT1, the deficiency of which can lead to glucose galactose malabsorption. GLUT5 helps in facilitate absorption of the fructose, the deficiency of which can lead to the fructose malabsorption, which needs to be differentiated from fructose intolerance, which is due to the deficiency of the enzyme aldolase B. So when it's come to the after absorption or uptake into the enterocytes, all these monosaccharides are exit the enterocyte with the help of GLUT2, which is present in the basolateral membrane of the enterocyte. So deficiency of the GLUT2 will lead to Fanconi-Bickel syndrome. So which is this GLUT2 is same present also in the proximal connectal tubule of the renal, so for reabsorption of the glucose after glomerular filtration. So Fanconi-Bickel present with GI and renal abnormalities. So then let's look at have a look at the lipids. The initiation will be in the stomach with the help of gastric lipase, followed by pancreatic lipase. End products are free fatty acids. Most of the short chain and medium chain fatty acids are absorbed by passive diffusion. Long chain fatty acids needs fatty acid transport proteins. There are 7 classes of fatty acid transport protein. Fatty acid transport protein 4 mutations detected till now. CD36 is a scavenging receptor which absorbs long chain fatty acids, and another transporter is sodium dependent bile acid transporter, which is present predominantly in the terminal ileum. After uptake into the enterocytes, there will be resynthesis of resynthesis of triglycerides, and which leads to formation of the lipoproteins, a chylomicron predominantly in the intestine. So microsomal transport triglyceride transport protein, which is essential in formation of the chylomicron, the deficiency of which can lead to A-beta lipoproteinemia. Decrease synthesis of ApoB can lead to hypo-beta lipoproteinemia, and SERP1 protein helps in transfer of vehicle from endoplasmic reticulum to Golgi apparatus. The deficiency of it can lead to chylomicron retention disease or Anderson disease, which leads to retention of the absorbed fats in the intestinal enterocytes. DGAT1 is the enzyme present in the enterocytes, which helps in resynthesis of the triglycerides with the help of fatty acids. Deficiency of which can lead to fatty diarrhea and congenital diarrhea in neonatal period. The rest of the fat acids are transported with the lipoprotein and lymphatics. So let's come to the proteins. Protein digestion begins in the stomach with the gastric pepsin and followed by pancreatic trypsin elastase. We have multiple specific peptidases on the brush-border membrane, and the end products are dipeptides, tripeptides, and amino acids. These are amino acids are taken up by the co-transport proteins which are present in the apical membrane. Di and tripeptides are taken up by the proton-coupled oligopeptide transporters. Till now, there are no cases detected due to the mutation of the proton-coupled oligopeptide transporters. However, there are diseases due to the mutation of these co-transport proteins. SLC A19 is the gene encoding for transport protein which transports neutral amino acids, and SLC7A19, SLC3A1, and SLC7A7 transports the cysteine, ornithine, lysine, arginine. These two can lead to the cystinuria, which is also, and these transport proteins are also present in proximal connectal tubule, which also helps in the reabsorption of the amino acids after glomerular filtration. That's why deficiency of this transport protein or mutation of the proteins of these proteins can lead to multi-system abnormality, GI and renal abnormality. And most of these transport proteins will present early in the presentation. Others are the SLC36A2 gene product, which transports glycine, arginine, and proline, which causes immunoglycinuria. And other is OCRL, which is the end product of it is the lysine arginine transporter. Deficiency of it leads to Lowe syndrome, which is achilocerebral renal syndrome. Now look at the etiological profile. We discuss mainly the enterocyte uptake and the burst bladder enzymes. So there are so many other diseases which can cause luminal abnormality. At the same time, enterocyte normal function abnormality due to inflammation. So let us look at the overall etiological spectrum. This can be categorized for the convenience into generalized mucosal diseases and depending upon the nutrient absorbed. When you look at the generalized mucosal diseases in older children, these are the gluten sensitive enteropathy, cow milk and other protein sensitive enteropathies, eosinophilic enteropathy, and when it's come to the other inflammatory disorders, and when protein losing enteropathy, lymphangiectasia and disorders causing small bowel mucosal inflammation. Others we have, when it's come to the congenital diarrhea, which presents as congenital diarrhea, congenital mucosal deficiencies, autoimmune enteropathies, and immune deficiency disorders, which can present in the early age with the multi-system abnormalities or with the IUGR as well. So when it's come to the congenital mucosal defects, it is a microvillus inclusion disease, tufting enteropathy, and glycosylation disorders, enterocyte heparan sulfate deficiency, and endocrinosis and trichohepatic syndrome. Autoimmune enteropathies can present with immune polyendocrinopathy or X-linked syndrome, IPEX-like, or autoimmune polyglandular syndrome, which also known as autoimmune polyendocrinopathy with mucocutaneous candidiasis and ectodermal dysplasia. Other immunodeficiency disorders we know can present with malabsorption and diarrhea, acquired immunodeficiency, and miscellaneous, which is Marshall bowel syndrome and radiation enteritis and immunoproliferative small intestinal disease post-transplant. Infections is one of the most common cause of malabsorption in the Indian spectrum. The chronic GI infestation with due to giardiasis, isospora, cyclospora, it can cause chronic infestation and malabsorption in children. Others are Strongyloides, Ballontium coli, which can cause predominantly IBD-like picture and colitis picture. And then when you look at the other etiologies with the according to nutrient.
Dr. Pandu, this is Dr. Ramesh Srinivasan. You have another 5 minutes to complete your presentation, please.
Okay, sir. I will focus mostly on the approach. So most of us know this is to early we have already discussed in the pathophysiology. Okay. So let's proceed. This is the list of the causes. So as we discussed, luminal hydrolysis is predominantly by the pancreatic insufficiency, and we can look at the exocrine pancreatic insufficiency causes and look at the enterohepatic circulation of bile acids and intestinal. So when to suspect? So most of the children with malabsorption present with diarrhea, more than 90%, and very few patients present only with weight loss, unexplained weight loss, failure to thrive or malnutrition. And they can present abdominal distension, increased flatulence, anemia refractory to iron supplements. These are the few red flag signs. Neonatal onset diarrhea should raise concern of congenital diarrhea, consanguinity and polyhydramnios, also congenital sodium chloride diarrheas. Presence of blood, mucus, suggestive of and rash, tax, visual suggestive of then IBDs. So diagnosis mind mapping, the history, physical examination, lab investigation, algorithm. So all of you know the history pertaining to digestive, systemic, neurological, in chronological age, followed by complete dietary history, and at the same time multi-organ involvement should be considered. Now let us the examination. One of the most important is assess the malnutrition and anthropometry. So we can come to a conclusion, or you can suggest of digestive system from the anthropometry. So we can differentiate from the growth failure. You can differentiate from whether it is the digestive or endocrine constitution from the anthropometry. When it's come to the digestive disease, the weight is severely affected compared to the height and length, height and the head circumference. When it's come to the endocrine, it is the length or which is severely affected, followed by weight and height. When it's come to the neurological, it is the head circumference which is severely affected, along with weight and length. Similarly, you can look, similar changes can be seen in the BMI as well. BMI severely affected in the GI diseases. whereas in endocrine it is modest and minimal in case of neurological syndromes. So I will rush through the examination. All of us know we have to go through from system examination to head to toe examination, look for signs of malabsorption and nutrient deficiencies, look for any skin and mouth and hair and nail and any rashes, suggestion of acrodermatitis enteropathica due to the zinc deficiency, can be congenital due to zinc protein deficiency. Let us look at the investigations. Investigation can be serum investigations, stool investigations, imaging, and endoscopy investigations. When it's come to the serum investigations, we have CBC, look for the anemia as well as absolute neutrophilic and absolute lymphocyte counts. In case of, there can be abnormality in case of immunodeficiencies, and absolute lymphocyte count can be lower in the protein-losing enteropathy secondary to lymphangiectasia. Look for the ESR-CRP, will be elevated in case of CMP as well as inflammatory bowel disease. Serum triglycerides can be low in cases of beta lipoproteinemia and hypo-beta lipoproteinemia. Serum albumin and protoprotein will be low in case of the protein-losing enteropathy. Look for the celiac serology, and next generation sequestration should be performed early in cases of suspected congenital diarrhea with the onset within less than 6 months of age. These are some investigations which are rarely used nowadays. Hydrogen breath test for the carbohydrate malabsorption. D-Zellers absorption test for the to know the intact small bowel mucosa. However, nowadays due to advent of the endoscopy and imaging, these tests are rarely performed. When it's come to stool investigation, so stool investigation, we have to look for any occult blood and white cells, look for any fecal pH and reducing sugar. Here the pH and reducing sugar should be performed within half an hour, which is a bedside test. When we perform late, then most of the time it can be negative or false negative. Then look for any fecal fat by Sudan IL stain, and look for an osmotic gap in case of severe watery diarrhea to distinguish between osmotic and secretory diarrhea. So let's come to the 72-hour fecal fat test. So this, though it is a gold standard for steatoria because of the 3 to 4 days procedure with strict dietary maintenance and stool collection for 3 days, so it is cumbersome, not performed nowadays commonly. So let's go to the stool elastase. It is the gold standard for exocrine pancreatic insufficiency. It is secreted by pancreas into lumen, highly resistant to proteases in the intestine, remains stable throughout the intestinal transit, high negative predictive value. However, it can be false in case of false negative in cases of diarrhea. Sorry, false negative. So in case of exocrine pancreatic insufficiency, you can approach with the help of fecal elastase. So elastase less than 100 microgram per gram stool is suggestive of pancreatic insufficiency, which also indicative of the pancreatic enzyme replacement therapy. The stool alpha-1 antitrypsin is again glycoprotein synthesized in the liver and secreted into the blood. It is a protease inhibitor, neither secreted, absorbed by the intestine. Normally present in low concentration stool. It can be useful in the confirmation of protein-losing enteropathy by random assessment, but definite is by alpha-1 antitrypsin clearance, which is less than 0.9 microgram per gram in normal cases. More than this suggestive of definitive for protein-losing enteropathy. Fecal calprotectin is a cytosolic protein secreted by the neutrophils. It is a non-invasive quantitative measure of the neutrophil flux into the GI tract and inflammation, which helps in the identification or diagnosis of the inflammatory bowel diseases. If the cutoff of more than 250 has good specificity of 80%. It is not well useful in children less than 4 years of age. When it comes to the imaging, we can have a wide variety of availabilities, X-ray, rectal abdomen, upper GI series for the structural GI abnormalities, contrast enema for the meconium plug, meconium ileus, and Hirschsprung in cases of cystic fibrosis, CCT abdomen to evaluate pancreatitis, CT enterography and MR enterography to evaluate the small bowel. These are the few picture source and upper GI endoscopy. This is the normal duodenal folds. Here you can see the scalloping, which suggests of villous atrophy, which is present in many of the infestation, and where is the characteristic feature of the celiac disease. Now let's go look at the algorithm. So as I told, most of the children with malabsorption present with diarrhea. So we can use the same algorithm for the diarrhea. Look for the red flag signs and do initial studies, stool for microscopy, stool for blood, and stool for fat globules, and also do Clostridium difficile enterotoxin in case of more than 1 year of age, and fecal calprotectin in case of children more than 4 years of age, and also do basic hematological investigation, full blood examination with ESR, CRP, and also celiac serology. So whenever there is positive infectious skin, treat accordingly. Positive celiac serology, do endoscopy, biopsy confirmation, and avoidance of the gluten. When in case of absence of white or red blood cells and presence of fat globules, we can still further, if it is, look for the fatty, it suggests a fatty diarrhea. And when presence of white cells or RBCs with the help and elevated ESR CRP suggests of inflammatory diarrhea, and absence of either white, red cells and fat, absence of fat globules suggests of what it is. This is the initial approach we have to, we can conclude whether watery diarrhea, inflammatory diarrhea, or fatty diarrhea. Next, we have to proceed according to the diarrhea. In case of watery diarrhea, look for any, so give a trial of fasting. If improves on fasting, it is osmotic diarrhea, and doesn't improve, it can be secretory diarrhea. So it watery diarrhea along with edema, hypoalbuminemia, and lymphopenia suggestive of the lymphangiectasia. We can further confirm the protein-losing enteropathy by alpha-1 antitrypsin clearance. Whenever there is osmotic diarrhea, further confirmed with the help of stool osmotic gap and stool reducing substances and acidic pH. Look at the age of the onset. When the age of the onset is infancy, so look for the short bowel syndrome and look for the congenital osmotic diarrheas. That can be disaccharide deficiency, and genetic studies for the congenital diarrheas. They need endoscopy and biopsy as well. When in the case of older children, you can do breath hydrogen test if it is present carbohydrate malabsorption or small intestinal bacterial overgrowth. In case of negative, go for endoscopy and biopsy and duodenal biopsy to evaluate the enteropathy. In case of secretory diarrhea, again look for the infancy. Infancy or in neonatal onset can suggest of congenital diarrheas, and evaluate further with endoscopy and clinical exam. In case of older children, look for the IBDs. In case of ESR, CRP, and also look for the neuroendocrine causes, which in the help of plasma VIP, gastrin, calcitonin for the neuroendocrine tumors. Inflammatory diarrhea, in newborn infants, it can be common protein allergy or very early onset IBD or PID, autoimmune enteropathy. When it's come to the older children, either is autoimmune enteropathy or IBD. Fatty diarrhea, it can be either secondary to the protein-losing enteropathy, secondary to primary intestinal lymphangiectasia, or it can be the exocrine pancreatic insufficiency, which is again the cause can be cystic fibrosis, the most common cause in children, followed by chronic pancreatitis. Others are Schwann-Diamond syndrome and Johnson-Blizzard syndrome. So management come to the most, irrespective of the cause, the specific management is according to the etiology workup, and general management, irrespective of the etiology, all children should be taken care of the acute malnutrition and ADEK and B complex supplements, multi-mineral supplement, thiamine supplement to prevent refeeding, and antibiotic whenever necessary, and monitor for the reseeding after initiation of the calorie or aggressive increase in the calorie supplements. Refitting syndrome is the severe fatal complication of the nutrition.
Dr. Pandu.
Sir.
Dr. Pandu, should we conclude here and then have it in the panel discussion?
Yes, so, sir. 1 minute is over. 1 minute is over, sir. Okay. So refitting syndrome can be due to decrease in the here we can see the diagnostic criteria. It can be due to the decrease in the phosphorus, potassium, and magnesium, or it can be thiamine deficiency developing shortly after ingestion of the calorie provision. So we can diagnostic criteria is by decrease in any one of the three, which can be mild, moderate, or severe, or due to thiamine organ dysfunction due to thiamine deficiency. So which occurs within 5 days of the reinitiating and substantially increasing the energy position. These are the risk stratification who are to know who are at risk, whether with the help of the BMI or can the anthropometry. We can classify them at risk. Sir, management is look for the potassium, phosphorus, magnesium, and start calorie slow, 40 to 50% of the goal, then slowly increase. And thiamine, add thiamine from 2 mg kg per day to maximum of 100 to 200 mg, multivitamin and multimineral supplements, and monitor the electrolytes initially 12 hours for 3 days and vitals. So the rest is specific according to etiology. Now I think I will conclude. Malabsorption is one of the common causes of GI dysfunction. Most of the cases present with diarrhea. Congenital diarrhea should be considered in infants. Stool investigation gives important clues. Endoscopy and biopsy needed in celiac, Ibd, and congenital diarrheas. Clinical exam in cases of infants and neonatal onset. Dietary therapy is important in most of the cases. Algorithm helps in the early identification and diagnosis. Thank you, sir.
Thank you, Dr. Pandu, for a very informative and talk filled with lots of facts. Now, in clinical practice, obviously everything is age dependent. Diarrhea and the cause of the diarrhea and malabsorption. Milk protein intolerance is very common, and persistent diarrhea because of various causes are also important cause of malabsorption. And one needs to remember about celiac disease, and we are seeing more and more cases of cystic fibrosis. So that should be sort of kept in mind also. Other structural abnormalities are important, which we need endoscopic diagnosis. And one important thing I would add is we are diagnosing lots of cases of malabsorption based on whole exome sequencing. So genetic sequencing has actually opened up a whole arena for us to know diseases which previously we would have missed. So that is particularly important. Thank you so much, Dr. Pandu, again.
Okay, sir.
Can you stop sharing the screen, please?
Okay, sir.
So now we have Prashant. Prashant, are you able to hear me? You have muted yourself. So we have Dr. Prashant Bachina, who is actually a consultant pediatric gastroenterologist and hepatologist working at Rainbow Hospitals in Banjara Hills. Dr. Prashant graduated and completed his post-graduation in Aurangabad, and then he trained in England in King's College Hospital, London, and Royal Free Hospital in London. And he basically is here to talk about inflammatory bowel disease in children and what is new about IBD. So Prashant, the next 20 minutes, we're just going to enjoy the presentation on IBD. Thank you.
Thanks, Ramesh. Somehow I'm not able to share the screen. Just a second.
Let's see if Dr. RSP can do it.
I think, Ramesh, you ask the next speaker.
No, Dr. Prashant.
There's some problem with the screen sharing. I'll get my IT guy to come and just sort it out.
No, Dr. Prashant, Dr. RC is joining now. He'll rectify the glitch.
Sorry?
Dr. RSV Sri Krishna is joining now.
You will help me with the screen sharing?
Yeah, be on the line. He'll come.
Something is, it's not, it goes to system preferences, it says.
RSV,
at home it worked. Now it's not working.
No, RSV is will be online and it will help you. Just.
Hi, Dr. Prashant. Which ID? You're already a co-host.
I'm using a Mac.
You're using a Mac because you're already a co-host. I'm just saying you're from the Prashant Bachna ID, right?
Yes, yes.
Yeah, really no reason to. Let me just make you a co-host again. Let's see if that works. Yeah, made you co-host again, Prashant. Just check now.
So again, I'll press screen share. It says desktop,
Yeah, so that should come up for us now.
but it says open system preferences rather than just allow. Normally, it just
No, no.
allows PowerPoint to
No, no,
come
no.
on.
See, go to Zoom, and once you press share, just click on the desktop as you see it. That's it. Once you're the co-host, you should be able to do. I mean, like the rest of the faculty have done.
I know. I've
Yeah,
done it
so-
several times. I've done it several
I know.
times, but it's not
Sometimes it's
working.
just a glitch and
It's
we won't
not
be able to come out. Mm.
screen share. Again, it comes to the same place.
Prashant, otherwise, should I ask Dr. Chandrasekharan to start and you can...
Yeah, you start. I'll sort this out in the next 5-10 minutes. You start.
Sure, sure.
Okay.
Dr. Chandrasekharan, I just saw him very briefly on the video. Sir, are you available? Good morning, Dr. Chandrasekharan. Good morning. So it's good to see you on the video. So is it okay for you to present now in place of Prashant is taking a little time before he gets ready?
Yeah.
So,
Be okay.
Yeah. Thank you so much for that. So first, I want to introduce Dr. Chandrasekharan. He is one of the most experienced and accomplished pediatric surgeons in Hyderabad city at this point in time. And he is an authority, especially in pediatric urology, where he has actually authored a book, which I sort of have seen on hypospadias repair. And he frequently has published meta-analyses related to pediatric surgery, which we are able to actually see on a pediatric academic group. So Dr. Chandrasekharan here is there to share with us a systematic approach to acute abdomen in children. So thank you, sir, so much for joining us today. And you can start screen sharing now.
Yeah. Thank you, Dr. Ramesh. Are you able to see my screen, sir?
Yes, absolutely. We are able to see it. Yes.
Yeah. First of all, a big thanks to the Twin Cities IAP branch, Dr. Subhoj Bhaskar, sir, who has been always a great senior colleague and great support ever since I had started practicing in Hyderabad for about 20 years now. When I was talking to Dr. Ramesh Srinivasan that this may not be a great topic to speak on, but then as I was actually trying to prepare for this, I realized what an important topic this is, and especially when we are speaking to the pediatric colleagues. So I will basically, so the objectives of today's talk will be, we will try to just summarize the common and rare causes of acute abdominal pain in children. And we will try to discuss some kind of an algorithm for workup and management plan for acute abdomen in children. Most of these are actually available on the internet. There are some very, very good lectures on the internet about this. So I thought with 20 minutes, whatever best I can do to summarize, we'll do that. And we will discuss some of the causes of common urgent and non-urgent pathologies of acute abdomen in children. And the talk is mostly from the pediatrician point of view, who probably encounters the patient first in the emergency room. I have specifically skipped the neonatal acute abdomen because that's a completely different topic with separate pathophysiology. So now what is acute abdomen? It's basically defined as pain abdomen due to non-traumatic cause of less than 5 days duration. I mean, these are very arbitrary terms, but again, trauma is probably not what we're going to discuss today. Non-traumatic pain abdomen is what we're going to discuss. Now, abdominal pain and related symptoms are very common complaints in children, and with I think with increasing incidence of bowel bladder dysfunction, we are seeing a lot of these non-specific pain abdomens in our clinics. It's a very frequent reason for presentation of children both to the clinic of the pediatrician and to the emergency room. Important to remember is most of the pain abdomen in children is of benign origin and may not be of an urgent nature. Of course, the parents always think it's urgent, but we need to know that most of them are benign and non-urgent nature. But I think the most important point is how do we identify the cases of acute abdomen that require urgent attention, and some can be life-threatening. So I think it's our job as the treating doctor in the emergency room to identify those patients who require an urgent attention. And most of these cases requiring urgent attention are usually surgical problems. Like, for example, if there is an intestinal obstruction requiring surgical treatment, the commonest being intussusception. If there is intestinal ischemia, this is something which we should not miss, something like a volvulus or the midgut in malrotation. If there is some kind of a perforation like appendix or Meckel's perforation, or if some kind of a bleeding is occurring from the lower GI tract because of Meckel's. These are some common things which we see, and these are the things which we probably should not miss, and we should identify these urgent causes. Now, typically, abdominal pain, we all know, falls into three categories. The visceral pain is what we see very commonly in children with constipation and gastroenteritis and all these common problems, common medical problems. It's usually dull, poorly localized, and usually it's in the periumbilical or in the midline region. Again, this usually signifies a non-urgent situation, whereas any child presenting with a parietal or a somatic pain, it's a slightly more urgent kind of a situation. This pain is because of a painful stimulation of the parietal peritoneum, typically indicates stretching of the parietal peritoneum or an inflammation. The inflamed, classic example of an inflamed appendix, touching the parietal peritoneum and then irritating it. And then this is also the pain seen in ischemic bowel. So it is usually sharp, intense, very discrete and well localized. Of course, small children, younger children may not be able to localize pain well, but in a slightly older child, they would be able to localize the pain well. And this pain is typically aggravated by coughing or movement. See, whenever I see a child with suspected acute appendicitis in the clinic, I ask them when they were traveling on the road by a car or other vehicle, if the movement on the speed breakers and all has suddenly increased the sharpness of the pain, that is again very typical of a acute appendicitis kind of pain. So otherwise we can ask them to jump down from the examination table, and if that increases the pain, then that typically signifies that it's an inflammation going on which is irritating the parietal peritoneum. Now, we also have seen patients with referred pain. I will never forget a child whom I was called for consultation for acute appendicitis. Now, the child had pain as well as typical tenderness in the right iliac fossa. But the child was coughing in front of me. When I asked the mother said the child had fever and cough, and then this pain started. We got a chest X-ray done. That X-ray showed a right lower lobe pneumonia. So, typically referred pain, can be a significant problem sometimes, which we have to consider to avoid a misdiagnosis of an abdominal problem. This is a very busy slide. We all know that anything in the abdomen can cause pain. A lot of gastrointestinal, genitourinary, metabolic, hematologic, hepatobiliary, and of course, miscellaneous causes. I'm not really concentrating on genitourinary causes for this talk because it's basically a gastroenterology meeting. Now, this is an interesting slide because we've tried to classify the causes of acute abdomen according to the age. I mean, what are the common causes of acute pain abdomen presenting in a child according to the age? Now, gastroenteritis is an extremely important cause. In fact, the commonest non-surgical cause of acute abdomen or acute pain abdomen is gastroenteritis in children, including from infants to up to 10 to 11 years of age. Whereas, from 2 years of age onwards, it's the appendicitis, which becomes the second or first most important cause. And that is the commonest surgical cause of acute pain abdomen in children. And with increasing constipation in children and altered bowel habits, we probably are seeing more and more appendicitis in children. And of course, constipation is an extremely important cause of pain in all age groups. Then the rest, like, intussusception has to be considered in any child less than 1 year and typically up to 2 years of age. Any child with bilious vomiting and an acute abdomen has to be considered as a valvulus malrotation unless proved otherwise, because that's a life-threatening situation. We have to rule it out at any cost. And of course, an examination of the genitals in a male child, in a boy, will tell you whether there is some testicular torsion, because the typical pain of testicular torsion actually presents in the lower abdomen. It's a dragging pain in the abdomen on that side, and then only it is localized to the testis. So an incrustated hernia or a testicular torsion can also cause, this kind of a pain. And many times the parents also may not have known. We have seen cases where the parents have come with pain abdomen vomitings, and then they have not noticed that there is swelling in the inguinal-scrotal region. And in older children, especially girls, you have to consider ovarian torsion, and even vaginal anomalies can actually present with severe pain abdomen. I'll discuss in the next slides. Now, I think an important task of the treating pediatrician in the emergency room is to correlate the child's symptoms with the differential diagnosis. So these are the kind of symptoms. If you have vomitings, then you consider the most important causes that should not be missed. So as I told earlier, the urgent causes like obstructions, perforations, peritonitis, volvulus and hemorrhage, they probably should not be missed. This is again the same thing. Now, what do we do when we are confronted with a child with an acute abdomen? I think there are some steps which we need to follow. Of course, the diagnosis will come as we take the clinical history, we examine the child and do some labs, and then maybe radiological investigations as necessary. But simultaneously, we should actually start managing the child from the word go. If the child is critically sick, or of course injury, we are not including trauma in this talk, but if there's a critically sick or injured child, then I think that's the most important thing you should take care of even before you arrive at a diagnosis. The general management, like looking at the hydration of the child, typically assessed clinically and also based on the urine output. And then if the child has high-grade fever, then probably the child will, even if it's an appendicitis or a Meckel's or perforation, I think the child will benefit from a shot of antibiotic, IV antibiotic, good IV antibiotic in the emergency room. And of course, the child is in severe pain, adequate pain relief can be provided. Again, this is controversial whether you should really give good pain relief to these children before the diagnosis is made. I'll come to that a little later. And of course, it's in any child with acute abdomen, it is better to keep the child nil by mouth, from the beginning itself, so that you give rest to the bowel and then you avoid any further discomfort to the child. Now, the most important thing is it's not a diagnosis made by one person. A teamwork is extremely important, including the pediatrician, sometimes the surgeon. I'll come to when to refer to the surgeon, and the radiologist, and the infectious disease specialist sometimes may be involved. Now, the most important thing is some common presentations can have some common pathologies can have uncommon presentations that needs to be remembered, and some uncommon and less common causes of abdominal pain also need to be kept in mind. And I think it's very important to communicate with the parents effectively, because in many cases, the diagnosis may not be reached immediately as soon as the child is seen in the emergency room. Now, how do we evaluate the history of acute abdomen? Of course, we need to ask for the location, the onset, the character, any change of location or the character. Typically, the pain of appendicitis starts in the periumbilical region, and then it localizes to the right iliac fossa. A pain of a testicular torsion typically starts in the lower abdomen, and then it localizes to the involved testicle. So these are some things which give us a clue as to what is happening. Of course, any severity and radiation of pain, and any precipitating or relieving factor factors, as we have discussed. Any precipitating factor with movement is typically indicating some inflamed organ inside the abdomen. Now, I think the most important thing is that the child is vomiting, then we need to be very clear what is the type of vomitus. In many situations, I have seen the pediatrician saying that it's a bilious vomitus when actually it is not a bilious vomitus. So let's be very clear, bilious vomitus is green colored. So yellow colored is typically not considered to be a bilious vomitus. So green colored vomitus is what we call as a bilious vomitus. So even one episode of bilious vomiting, of course, there are some children who have bilious vomiting without an obstruction, but any child with even one episode of bilious vomiting should be evaluated for intestinal obstruction unless proved otherwise. So and then the bowels, the frequency, and any evidence of blood in the stool. Blood in the stool typically indicates either an infective condition or ischemic condition, or a bleeding directly into the gastrointestinal tract, like a Meckel's diverticulum. Of course, urinary symptoms, respiratory. As I said earlier, sometimes the pleuritic pain and the pain of the right lower lobe pneumonia can mimic acute appendicitis. So any respiratory symptoms and some systemic conditions can present with acute abdomen. So you need to check whether the joints are involved, the joint pain, any rash or any purpura or any sore throat. Sore throat, typically the viral upper respiratory tract infection with a sore throat can typically present with a pain abdomen. We sometimes call it a tonsil tummy. And many times these children have mesenteric lymphadenitis, which is very non-specific, but it can be mistaken for an acute appendicitis. Now, in older girls, we are now seeing some older girls coming to us with menstruation-related problems. So we need to take that kind of history. Whenever we are suspecting, if necessary, we can take a gynecology consultation also. And any past history of medical, surgical, or family history. If a child with a sickle cell, known child with sickle cell anemia presents with pain, acute pain in the left abdomen, then it is a splenic infarct unless proved otherwise. So a past history is very important. At the same time, any child who had any previous surgical intervention on the abdomen, typically can present with adhesive intestinal obstruction, and the adhesions can be the cause of pain. So these are some things which are very important. With the advent of laparoscopy, you may not actually see a big scar on the child's abdomen. So many times when the previous surgery was done laparoscopically, then you may not see any scar, but you need to always ask the family whether the child underwent any abdominal surgery previously. Now, apart from the general examination, a shallow breathing basically indicates that there is some inflammatory, painful pathology inside the abdomen, irritating the peritoneum. Now, any distension, we all know how to assess abdominal distension. Is the child able to localize the point of pain? What is the tenderness like? Is there any guarding or rebound tenderness? Guarding, rebound tenderness, they all indicate irritating, inflammatory pathology intra-abdominal. And of course, bowel sounds. Of course, most of us listen to bowel sounds for a few seconds, but ideally, we should take some time and listen to bowel sounds in all the 4 quadrants. With the availability of good radiological investigations, I think most of the clinical examination has lost its importance, but I think it's very important that you do a cursory clinical examination, keeping all these points in mind, especially as we discuss a genital examination and then a rectal examination. An abdominal examination is never complete without a genital and a rectal examination. They might give valuable, for all you know, the child may be having a perforated appendix with a pelvic abscess. So when you put your finger in the rectum, you will find that boggy swelling anterior to the rectum, and you actually made the diagnosis even before an ultrasound has been done. So typically, the investigations are very variable based on the differential diagnosis. Of course, because the common causes are inflammatory and like appendicitis, we need to obtain a CBP, differential count, CRP, then urine examination, because a urinary tract infection can typically present with acute abdomen in children. Then if we are suspecting clinically an upper abdominal pathology and something like pancreatitis, then we need to hepatobiliary problems. We need to do an LFT and serum amylase lipase. Of course, in children with suspected, either peritonitis or perforation, or even in children with suspected suspected that abdominal pain is because of constipation. And abdominal X-ray is one of the best ways to actually confirm that the child has significant constipation and fecal retention. You ask the parents will say, no, our child is passing stool every day. But, you take an abdominal X-ray, you know that the entire large bowel is filled with stool. And you know that this child is constipated. That's the most likely cause of the pain abdomen. Of course, a chest X-ray when you're suspecting a respiratory problem, an ultrasound and a CT. I'll come to them in a while. Now, I think the key points when you the pediatrician has to remember when they are examining an acute abdominal pain in a child is, in most instances, the probable cause of acute abdomen, the differential diagnosis can be made by a good history and clinical examination. Whether the most important thing, as I said, I'll be stressing it time and again, that you need to distinguish the urgent cases from the non-urgent cases. In medical causes, typically a child presents with vomiting and pain. If the vomiting has started prior to pain, then it's more likely a medical cause. Whereas if the pain has started preceding the vomiting, then probably you're dealing with the surgical cause. These are very simple, points, but I think they make a lot of impact when you are actually on the ground level examining the child. Now, it is important to distinguish, as I said, from non-urgent from urgent cases. And I think a very important thing when you're not sure what is happening to this child, you probably think it's appendicitis. You're not sure. It's not very typical. Or probably the child has present within the first 6 to 8 hours after the onset of symptoms. And then you probably, a very important thing is to keep the child observed and a repeat clinical examination at regular intervals by the same physician who have seen the child initially helps immensely in getting a conclusion whether the child is actually improving or deteriorating or any other clinical signs are actually becoming apparent as the time progresses. Of course, appropriate pain relief has to be given to these children whenever they come to the emergency room. Again, there are two arguments. Some of us may argue that, if you give the child a good pain relief, then it may mask the symptoms and signs, and you may not be able to clinically diagnose important pathology later. But actually some authors have actually found that giving pain relief is actually beneficial, because then the child would actually permit a better and a more comfortable clinical examination. Then this is basically if the abdominal pain with distension, focal tenderness, and peritoneal signs, and you have to, first thing you have to rule out is peritonitis, which may be a perforated viscous or a volvulus, which may require an urgent surgical consultation. Then the next comes intestinal obstruction. Intestinal obstruction is not that kind of a dire emergency as a perforating peritonitis. You have enough time to work up the child, probable cause of intestinal obstruction, and then you can go ahead with the management. The third in the row of urgency, in the decreasing order of urgency comes things like acute appendicitis. I mean, you have time to evaluate the child, you have time to get a surgical consult, you have time to get an ultrasound, and in case of doubt, you have time to get the CT and then proceed. Of course, conditions like acute pancreatitis, cholecystitis, or cholangitis, they are mostly non-surgical conditions, so you can evaluate them and then treat them medically accordingly. Now, what are the indications for surgical consultation? We need to remember that it's only about 1% of children presenting with acute abdomen that require surgical intervention. So 99 out of 100 children do not require a surgical intervention. That doesn't mean that we are not going to get a surgical consultation, in 99% of patients. But so whenever there is whenever these following signs are there, that severe increasing abdominal pain with progressive signs of deterioration, this is where, as we discussed, repeat examination, keeping the child in observation, repeat examination by the same physician is very useful. Whenever there is a bile stain or a feculent vomitus, that's an urgent surgical consultation. Then abdominal guarding rigidity, rebound tenderness, again surgical. As I said, any typical parietal kind of pain, is an indication for surgical consultation. A marked distension and signs of acute fluid or blood loss into the abdomen, or signs of perforation peritonitis, is all an indication for surgical consultation. Now, before we label a child as having an intestinal obstruction requiring laparotomy, we need to remember that some of the some of the clinical conditions can actually mimic intestinal obstruction, but they are both usually functional intestinal obstruction because of the bowel irritation caused by the inflammatory conditions inside the abdomen. Now, some common causes of acute abdomen, we'll just very quickly brush through. We all know these conditions. It's just to re-emphasize the importance. Appendicitis is typically a very important surgical emergency in childhood. As we said, it's probably the commonest cause of acute abdomen in any child over 2 years of age. Diagnosis, we must remember, is difficult in two situations. Although appendicitis can typically be diagnosed very easily by most clinicians, in two situations. One is the age of the child. A younger child, it's very difficult to diagnose many times. And secondly, the appendix is actually in an abnormal position. Based on the position, that can be difficult. There are clinically, there are two types. One is a catarrhal appendicitis. Acute catarrhal appendicitis typically occurs with a viral or a bacterial systemic infection. Many times it may be able to manage these cases conservatively, but most of them ultimately may require surgery. But the most important thing to beware is the obstructed kind of appendicitis, where a fecalith is obstructing the lumen of the appendix. These are the children who deteriorate early, and if the diagnosis is delayed, these are the children who are likely to perforate and cause complicated appendicitis. So inflammatory or suppurative appendicitis, whereas gangrenous perforated appendicitis or a mass, appendicular mass or an abscess are typically a result of obstructed appendicitis because of a fecalith obstructing the lumen. Now, we all know the typical features. I need not elaborate them, but just see that we don't miss, just keep in mind that we don't miss the atypical appendicitis. Only we frequently see children who have a retrocecal appendix or a retroileal or a pelvic appendix. Typically, a pelvic appendix typically presents with diarrhea and urinary symptoms. So they are typically diagnosed as gastroenteritis or urinary infection, and then they are managed in that way. But by the time they are picked up, many times they are actually perforated with an abscess in the pelvis. So we need to remember that appendicitis, when an appendix is in an atypical position, it can present with atypical features, and we need to keep this in mind as an uncommon presentation of a common pathology. Now, we know that the routine labs would show leukocytosis and neutrophilia. Now, the ultrasound is the cornerstone of diagnosis and confirmation of acute appendicitis. Of course, it has its pitfalls, but it's very important, because I have seen patients with right-sided ureteric colic presenting typically with appendicitis. In fact, they have even the tenderness because of the dermatomal irritability in the right lower abdomen. But they look like appendicitis. The ultrasound shows actually there is a stone in the ureter causing the colic. So ultrasound, if it can see the appendix, they can diagnose whether it's, for example, if they can visualize a normal appendix, the radiologist can visualize a normal appendix in all its length, from the cecum to the tip, then they can actually rule out appendicitis. But the typical features of acute appendicitis are any appendix diameter more than 7 millimeter. I think more importantly, the wall thickness of 3 millimeter or more. Periappendiceal fat inflammation is very important. Non-compressibility of the appendix. We see this sentence in most of the radiology reports, a non-compressible structure, but that is very high false positive rate. It's not considered to be a very specific, sign of acute appendicitis. So even though the radiologist would report it, we must actually take it with a pinch of salt. The presence of a fecalith should raise a significant suspicion, although fecalith in the appendix has been demonstrated in some completely normal and asymptomatic children. But in the presence of clinical signs and symptoms of acute appendicitis, with other signs, then the presence of a fecalith in the appendix they can pick up, then you must take it as an urgent case of obstructed appendicitis. Of course, signs of perforation or abscess will be either clinically evident, or you can actually make it out on the ultrasound in the form of a collection with some pus, inside the abdomen. Now, I'm not a great fan of doing CT for all cases of acute appendicitis. In fact, I think as pediatric specialists, we must actually be very careful that we avoid the radiation given by unnecessary CT scans in children. But having said that, there are some specific indications for CT. Recurrent pain abdomen, which are partially treated, chronic pain abdomen, partially treated case, especially you're not sure of the diagnosis. The late presentations, as we typically said, something like the atypical typical presentations of either retrocecal appendix or a high placed appendix, subhepatic appendix, or a pelvic appendix. Then when you are suspecting complicated appendicitis with an abscess or a collection inside, especially when the ultrasound is non-conclusive in such cases, then any child with equivocal clinical signs this is a typical CT, one of our patients showing an appendix in the very high appendix, retrocecal, and the subhepatic position. This child had abdomen in the had pain in the upper abdomen. So there was a very this one about the diagnosis. This is a pelvic appendix showing a perforation with pelvis pus collection in the pelvis. Now the management, we all know the treatment of choice currently is laparoscopic appendicectomy. I probably have not done an open appendicectomy for about 15 years now. All even complicated appendicitis like mass, abscess, perforation can be managed adequately by laparoscopy in expert hands. And in fact, laparoscopy has far greater advantages in complicated appendicitis than open surgery. We all know the advantages of laparoscopy, of course. Now, the second condition I want to discuss briefly is malrotation or volvulus. This is one condition where diagnosis should not be missed. Any child, I am again stressing this again and again, any child with bilious vomitings without distension should be evaluated for malrotation, because malrotation typically causes an upper gastrointestinal obstruction. So distension would appear much later. If a child with malrotation is getting distended, then we are in deep trouble, because that means he's going into gangrene. He or she is going to gangrene, volvulus and gangrene. So any child with bilious vomitings without distension should be evaluated for malrotation. Just like we evaluate any non-bilious vomitings in a child for a gastric problem, any bilious vomiting we should evaluate for a malrotation. Now, valvulus, as we said, may present with acute abdomen at any age, typically in the first couple of years of life. When volvulus occurs, there will be almost like a gasless abdomen, except little gas in the upper abdomen. It will be a gasless abdomen on the plain X-ray. Ultrasound may demonstrate a supramesenteric artery vein reversal. Of course, these children are very cranky. They may not allow a proper ultrasound examination. So the upper gastrointestinal study is usually conclusive. Here you can see one of our patients where the entire small bowel is on the right side of the abdomen. The DJ has not crossed the midline. In fact, the DJ should be going across the midline. DJ has remained on the right of the midline, and the upper small bowel loops are all in the right upper abdomen. So they're typical of malrotation. And if we are suspecting only malrotation, no volvulus, then you can work up the child and then go ahead with surgery, but still an urgent surgery would be required. But whenever a volvulus is suspected, then an immediate exploration to save the bowel is mandatory. Of course, these procedures can be done now comfortably by laparoscopy in most cases. Now, coming to intussusception, we all know commonest is ileocolic. It's a very common abdominal emergency in children, especially in infants. We all know the diagnosis. Ultrasound is very sensitive for the diagnosis. Here, a word. Many children have these fleeting small bowel to small bowel intussusceptions, and many of them need not be taken very seriously unless it's a ileocolic intussusception, the typical ileocolic intussusception. That is what needs to be taken very seriously. And transient small bowel intussusceptions are very common, and they cause transient pain abdomen, and many of them can be actually observed. Whereas a classic intussusception of the ileocolic type presenting in a small baby requires urgent attention. And stabilize the child, confirm the diagnosis. Again, ultrasound is the crux of the diagnosis. And surgical management, either by hydrostatic or pneumatic reduction or laparoscopic reduction. We actually described an alternative technique of laparoscopic assisted reduction of intussusceptions long ago. Of course, open surgery still has a role, but is reserved for late presenting cases with gangrene, which may require resection and anastomosis. Now, Meckel's diverticulum, it's the most frequent congenital bowel abnormality in about 2% of the population, but not many of them will become symptomatic. Very variable presentation. Diagnosis, that's why may be difficult. So many cases present with acute obstruction. Sometimes the diagnosis can be made only during the surgery. In intestinal obstruction, you only need to decide whether you have to operate or not. And you probably don't have time to evaluate further. Sometimes CT scan may pick up the diverticulum when you are suspecting it. But most important thing is in children present with rectal bleeding, then technetium scan can pick up ectopic gastric mucosa in about more than 80% of cases. That's very important investigation to keep in mind. Typically, a CT scan showing an appendix, a Meckel's diverticulum, which is stuck to the umbilicus. So I'll show you the operative photograph in the next slide. This is a child who presented with a significant rectal bleeding, painless rectal bleeding, and a scintigraphy showing ectopic gastric mucosa in the Meckel's. So as we said, it's present in more than 80% of patients. So it can be picked up in many situations, can be picked up in the nucleus scan. Now, that child who was presenting with Meckel's diverticulum attached to the umbilicus. So this was an inflamed Meckel's which attached to the umbilicus. So we picked it up on the CT, then we did a laparoscopy, and then what we do is we enlarge the umbilical incision, we exteriorize the Meckel's outside. Here you can see the inflamed Meckel's diverticulum with the attached small bowel. So we resect and rejoin the small bowel, and then we put it back through the umbilical incision so that the child has a very cosmetic result. It is basically laparoscopic assisted surgery. Now, acute pancreatitis, we all know etiology can be multifactorial. It's not uncommon. We see acute pancreatitis in our practice reasonably commonly, I would say. The symptoms can be pain, vomiting, distension, and fever. We typically know elevated amylase lipase levels are used to diagnose. Ultrasound may be difficult to pick up because of the bowel gas. So CT or MRI may be necessary. CT especially can assess the severity, and it can differentiate an edema of the gland from necrosis. Because if you have a necrotizing pancreatitis, that becomes a real a nightmare for the intensivist to manage. And MRCP is typically done usually after the acute episode, mainly to pick up any hepatobiliary anomalies like, any ductal anomalies, or to pick up any stones in the CVD, which may be actually causing the acute pancreatitis. Management in most cases is conservative, and acute intervention is usually required very rarely. Here you can see the MRI showing edematous pancreas. Here you can see the CT scan showing a necrosis of the pancreatic head and a large collection in the peripancreatic area. So the important thing is to follow up after acute pancreatitis. We need to keep them under follow-up. Of course, we have to find out and treat if there is any cause. We recently had a child who had cholelithiasis who presented with pancreatitis. So I think by the time he came, the stone had passed, but it had actually caused acute pancreatitis. So we treated it, and then on follow-up, he had a laparoscopic cholecystectomy. So similarly, when there is a peripancreatic fluid collection, we need to follow it up with a ultrasound or a CT scan, and by about 6 weeks, if it's not regressing and it has actually formed a nice thick walled cyst, pseudocyst as in this case, then the child might require an intervention for the pseudocyst in the form of either an endoscopic or laparoscopic or open. This is a child who underwent a laparoscopic cystogastrostomy for a large pseudocyst following a acute pancreatitis. Now, one of the last things I want to discuss is adnexal torsion in older girls. We have seen these patients. Many of my friends from other parts of the country have also seen these girls. This is something which we do not suspect very often, but we need to keep this in mind whenever a girl typically, pubertal or prepubertal girl presents with pain abdomen, especially lower abdomen, nausea and vomiting. Ultrasound is usually diagnostic, but we must ask the radiologist to look at the pelvis clearly. Ultrasound shows typically an enlarged ovary because of edema, and the follicles are displaced peripherally. You can see here very typically the enlarged ovary, follicles have been displaced peripherally because the ovary becomes edematous because the torsion first stops the lymphatic flow, then venous, and then arterial flow. Ovary has a dual blood supply, so the arterial flow may not be affected till very late. In doubtful cases, of course, CT or MRI may help. And whenever we are confirmed adnexal torsion, they require an urgent laparoscopy to first establish the diagnosis and then to detort the ovary. The necrotic ovary may be partly debrided, but we do not try to excise ovaries in children so easily. We try to preserve as much ovarian tissue as possible, because many of these ovaries which look bad during surgery actually have been shown to improve and start functioning some function after remove in most cases and save as much ovarian tissue is the rule. You can see the torsion here of the adnexa. And important thing is we need to pex the ovary on both sides so that it doesn't rotate again, because it's like testicular torsion where you pex the opposite side also, preemptively, so that in future it will not undergo torsion. Now, another very important, very common cause of pain abdomen we see in the outpatient clinic. So mesenteric lymphatitis. Many children have viral infection, URTI, pharyngitis, recurrent intermittent pain. They typically do not have the clinical signs like tenderness and guarding of acute appendicitis. Ultrasound is typically helpful in diagnosing a mesenteric lymphatitis. Conservative management, but you should always entertain the diagnosis of lymphoma in your mind. We have seen patients with mesenteric lymphatitis presenting with pain, but they turned out to be lymphoma later. So basically, you need to keep a differential diagnosis of lymphoma in your mind. Whenever you see multiple nodes, very large nodes, typically you have to suspect lymphoma and then proceed according to the investigations. Now, one of the last slides, importance of genital examination in acute abdomen. This is a child, as I said, the child was crying incessantly and having non-bilious vomiting. Luckily, didn't go into obstruction. But then we found that this child had an incarcerated hernia, which was actually reduced and repaired laparoscopically. This is a recent patient whom we operated. This child is a teenager who came with pain in the lower abdomen for 3 days duration. And finally, on the 4th day, they realized that it was actually the pain was in the right testis and left testis. And this was actually a torsion of the testis. You can see here the severe discoloration of the testis. There was some bleeding when we incised the tunica. So we decided to save the testis, but we are not sure how much this testis is going to function. The diagnosis was probably delayed because the parents thought it's just some vague lower pain, lower abdomen. They consulted the pediatrician only on the 4th day, and that was immediately picked up by the pediatrician. So we need to be very careful to tell the parents not to ignore, pain abdomen, which is continuing for more than 12 to 24 hours. Now, this was a child who came from Bangalore. We operated a couple of months ago. This was a 15, 16-year-old girl who started having, severe pain in the lower abdomen for many months, which was thought to be constipation and treated, and finally it was realized that the child had a uterovaginal anomaly. The child had cervicovaginal atresia. So the uterus was bleeding and the blood was accumulating and there was severe hematometra. The child also had 2 hemiuteri to make it complicated. The child had 2 hemiuteri, both were filled with a lot of blood, and that's why typically the child had cyclical pain abdomen. It took about 5 months for this to be diagnosed, and of course we finally ended up removing both the hemiuteri by laparoscopy. So clinical examination of the external genitalia would have revealed that there is a vaginal atresia in this child. So again, I'm not going to go into detail about this. Important causes, systemic causes of acute abdomen. We all know this. We have to just keep in mind. So I will just stop here. Maybe some take-home messages with systematic evaluation with history and clinical examination is very important. Investigations have to be tailored according to the differential diagnosis. Rare conditions are rare but need to be remembered. We need to differentiate between urgent and non-urgent conditions, surgical and non-surgical conditions. We need to rule out life-threatening conditions first. A repeat examination by the same physician in case of doubtful severity is usually helpful. A timely surgical consult and intervention is important, keeping in mind the red herrings to indicate a surgical problem. We need to remember atypical presentation of a common pathology like acute appendicitis. Taking parents into consideration is extremely important, and I think teamwork is the key. Thank you so much.
Thank you so much, sir. Thank you so much for actually condensing several chapters of surgical textbook into a small 20-minute talk. That was very, very useful for all of us. And you brought in several points about the importance of clinical examination, as well as how to use movement or jumping as an important indicator of parietal involvement in inflammation, like in appendicitis. We do a jump test on several children to actually see whether they're able to jump properly. They're not able to jump, then we think it's a significant inflammation. Importance of hydration in management, surgically. Most of the times, the abdominal pain we are seeing, you said 99%, they don't require a surgical consult. Only 1% requires a surgical consult, really. So that was very important. Most of the times, constipation has been a great mimicker of several conditions related to the abdomen. And non-specific mesenteric adenitis, there seems to be an epidemic of that. Anytime you send for an ultrasound, they come back with the non-specific mesenteric adenitis. We are always taking 15 millimeters on the short axis view of the lymph node, suggestive of less than that being normal, more than that being indicative of some problem. But if there's a generalized lymphadenopathy or there's a suggestion of systemic disease, then we are really worried. Majority of times we are seeing many children are even put on empirical ATT by some physicians, pediatricians, etc., because they think the mesenteric lymph nodes are big. But we are trying to dissuade them. Unless we have a clear diagnosis, we are not going for that. And one other clinical point or observation is majority of children with mesenteric adenitis also seem to be constipated. This has been my observation and observation of several others in this field. So that is something very important, sir. We'll come back to you during the panel discussion, sir. Thank you so much for such an informative talk. Thank you.
Thank you.
So Prashant is now back with all the technical support. So Dr. Prashant Dachina from Rainbow Hospital. So he's going to talk us about inflammatory bowel disease and what is new in inflammatory bowel disease. Prashant, are you on? Is everything okay technically? Can you slide share, please?
Ramesh, are you able to see the screen?
Yes, yes, I'm able to see the screen, Prashant. It's very pretty.
Just a second to see if it moves. Okay. All right. Sorry for the technical hitch. So pediatric IBD is, the landscape is rapidly evolving, and we take a lot of clues from our adult colleagues in terms of management of the IBD, in terms of using newer molecules. But pediatricians are leading their way in terms of monogenic IBD, understanding the pathophysiology between monogenic IBD, enteral nutrition as a form of treating IBD. So I thought, rather than going through all the tongue twisting molecules of IBD, I will just focus mostly on Veo Ibd, which was very important for the clinicians to pick it up and refer to the gastroenterologist. And then I will touch on the newer molecules that are available. So this is going to be the general outline for the flow of my talk today. In the next 20 minutes, I'll be covering a fair bit of ground. So let's start from where we came. So we have come a long way from, IBD has been described as early as the 1st century, but only in the 1760s, that Giovanni Battista Morgagni, a very towering personality in those days, described a 20-year-old man with features of IBD. And when this person died, he was an anatomist. He performed an autopsy and described erosions, ulcerations, perforations in this child. And then as 150, 200 years later, Burrill Crohn's, Oppenheimer, and Gunsberg finally published a paper called Regional Ileitis, which nowadays we call as IBD or Crohn's. So that was the first time a proper description was given. And then as time progressed, we got to see the different management of IBD, like how the role of prednisolone, mesalazine, the monoclonal antibodies. And in 2020, we have far more number of antibodies, which I will touch base during the course of the talk. So the GI tract is one of the largest lymphoid organs, and it has a plethora of cells: the goblet cells, the enteroendocrine cells, the Paneth cells, And beneath this, there is a huge amount of T and B cells. Imagine this lymphoid organ being challenged day in and day out by the food that we eat, the bacteria that move out in the lumen of the intestine. So this harmony between the luminal contents of the bowel and the gut immune system maintains the homeostasis. When there's a breach in this homeostasis, it leads to various conditions, one of which is IBD, which has histologically been described as ulcerative colitis, Crohn's disease, and indeterminate colitis. Veo Ibd, or very early onset IBD, is a newer form, or it's probably described since 2005, and we now know that Veo Ibd is a monogenic variety of IBD. It is seen in the very young kids, and it is quite different to adult onset IBD, which I will be telling later. So Veo Ibd is not influenced by environmental factors like adult onset IBD. On the contrary, it is based on a monogenic problem in the child. The breakthrough came in 2005 when Glocker et al. First described a Mendelian mutations of the IL-10RA and RB in a child with infantile onset IBD who had all the typical symptoms of bloody diarrhea, failure to thrive, and perianal disease. And then this was picked up for the first time. And then from that time onwards, we have identified many more monogenic variants. So the location, the progression, and the treatment of Crohn's depends upon the age. So that's why there's the Paris classification, which said pediatric IBD less than 17 years, early onset IBD less than 10 years, very early onset IBD less than 2 years, and infantile onset IBD less than 2 years, and neonatal onset IBD is less than 28 days. So the IBD is most common in the age group of 15 to 30, and a quarter of these patients present in the pediatric age group, and 1% of this pediatric IBD is Veo Ibd. And the epidemiology says that it is almost 4.37 per 100,000 in terms of incidence, and prevalence is 14 per 100,000. The incidence of pediatric IBD, particularly Crohn's, has been rising both in the developed and developing countries, as my gastroenterology colleagues must be seeing. In adult onset IBD, when you meta-analyze the genome-wide association studies, they've detected around 250 single nucleotide polymorphisms over 300 genes, which could affect IBD. So basically, adult IBD is that you have a genetic predisposition and you have the environmental factors and the gut microbiome to cause the IBD. Whereas in children, especially the monogenic variant, they've identified a single gene mutation which can present like IBD or IBD-like colitis. So if you look at the bottom half of the screen, where it says early onset, so genetics predominate, and on the right side, you see there is a late onset where you see the environmental factors being predominant. So monogenic IBD versus Veo Ibd. Not all Veo Ibd are monogenic. So the only ones which have the monogenic mutations behave in a more aggressive manner, and they are more refractory to treatment compared to the normal IBD that we see. So Veo Ibd without monogenic IBD most likely behaves like the adult onset IBD. So there are different pathogenesis and functional subgroups that have been described for the Veo Ibd. One subgroup mentions about the epithelial barrier and response defect. So there, the epithelial barrier of the intestine is damaged. Hence, a plethora of conditions can arise because of that. Then the second category looks at defective granulocyte neutrophil function. So where you have diseases like CGD. Then you have hyper and autoinflammatory disorders, complex defects in B and T cells, regulatory T cells, and IL-10 signaling. So if you look at the epithelial barrier and response effect, the epithelium forms like I said, forms a protective barrier between the luminal contents and the immune cells in the submucosa. So if this barrier is damaged, it can lead to various conditions. TTC7A is one of the prototypes in this category, where there is a damage to the epithelium. It can manifest, the most severe form can manifest as multiple intestinal atresia with a skid-like phenotype. So they have combined immunodeficiency along with multiple intestinal atresia. And the lesser phenotype can present like a typical IBD. Then you have the phagocytic defects, like I described, the ones which have problem with neutrophil migration or the NADPH burst. All these conditions also can manifest like IBD. Then you have hyper IgM and Wiskott-Aldrich syndrome, which Aldrich a lot of us have seen. So they present with eczema, platelet problems, and ulcerative colitis-like phenotype. Then you have hyper or autoinflammatory conditions, like especially like mevalonate kinase deficiency, which can also lead to the features of bloody diarrhea and failure to thrive. And in this category, where there is immunoregulation defects, all of us have seen IPEX at some point, especially the gastroenterologists. IL-10, RA, and RB are the rare ones which have been described since 2005. And IPEX is basically an X-linked condition with polyendocrinopathy, enteropathy, and an immune problem. And IL-10, RA, and RB, like I described before, are because of the mutations in the IL-10 inflammatory marker and the receptor, which plays a low role like a anti-inflammatory cytokine. So it balances the pro-inflammatory and anti-inflammatory cytokine. Hence, IL-10 has been amongst the center of research in the IBD world. So when to suspect monogenic IBD? When the onset is very early, when there's a family history of an adult, of a similar child who has similar symptoms and has passed away or had a similar course, atypical endoscopic and histological findings, resistance to conventional therapies, like when you use steroids or monoclonal antibodies, it doesn't work. Skin lesions are common, especially folliculitis, severe and very early perianal disease. And so I typically say that somebody who has perianal disease, not responding to antibiotics, not responding to elemental formulas, suspect Veo Ibd. Lymphoid organ abnormalities, they are more predisposed to lymphomas, HLH, and associated autoimmune conditions. So why should we care about monogenic defects? Because these kids fail conventional therapies, and one size or one shoe doesn't fit all of them. So if you think about IL-10, they can be fixed with a bone marrow transplant. But if you look at epithelial barrier defects, they cannot be fixed by a bone marrow transplant. Whereas mevalonate kinase deficiency and CGD are associated with IL-1 problems, and you have a specific antagonist to tackle this ILB. So you can tailor-make their treatment based on what monogenic IBD you're dealing with. So hence we should know and we should care about these conditions, because you can tailor-make their treatment protocols. And also we can anticipate malignancies. So clinical features: a young child at onset, less than 6 years, a family history of IBD, family history of autoimmunity, recurrent infections, which is a mark of immunodeficiency, early onset perianal disease, skin and joint lesions, and lack of response to conventional medications. So typically we do endoscopy and histology, which is most of the times in my experience has not been very useful in coming to the diagnosis of the condition. It just tells that you have features of colitis or Crohn's, but you don't know what is causing the underlying condition. Stool culture and stool viruses just to rule out the infective pathologies, IgA, IgG and IgM for the hyper IgM syndromes, flow cytometry, and the NADPH burst for the neutrophil defects. And like we said, IL-10 is the center of research because of its balancing act. It balances TNF alpha, IL-1, IL-6, IL-12, and it can give you an anti-inflammatory environment in terms of IBD. So differential diagnosis, typically all the infections, allergic colitis and CMPA, eosinophilic colitis, primary immunodeficiency syndrome like SCIDS, Wiskott-Aldrich, IL-10RA, Hermansky-Pudlak, and autoimmune enteropathy. I just described 2 or 3 cases. So we had a child who was born to non-consanguineous couple, had history of blood in stool since 2 months of life. He had recurrent episodes of colitis, which were culture negative and had no response to antibiotics or elemental formulas. One of my colleagues even suggested me to treat with anti-tuberculosis medication, which are again of no use. Perianal disease started at 5 months of age. Colonoscopy suggested a Crohn's-like picture. And this kid at 9 months of age developed skin lesions, and there was a history of similar elder sibling who died with similar symptoms. And when we did the clinical exam, we got an IL-10RA and we sent him for a bone marrow. And now, by the grace of God, he's doing well. He's now 6 years old and doing very well, going to school. The second child was a child born to a consanguineous couple with a history of first child death due to sepsis. There was a history of recurrent fever since the age of 2 months, history of, again, recurrent bloody diarrhea. Colonoscopy at 6 months was suggestive of Crohn's, and the perianal fistula also developed at 6 months itself. Non-responsive to conventional treatment, and we had a IL-10RB mutation. Unfortunately, this child was not as lucky as the first child. So despite undergoing a bone marrow transplant, he died after 1 month due to sepsis. But the story doesn't end here. So this family lost 2 kids. So what we did, we did a prenatal diagnosis. My wife does fetal medicine, so it was very handy. So I asked her to do an amniocentesis, and then third time they got lucky. There was the same mutation was not found in the third child. And now they're blessed with a baby girl. And I met them. The family is now relocated to Dubai. So when I went to Dubai, I did make a social call to them. And that child is now 4 years old. And a third child, a 3-month-old boy, was born to consanguineous parents, presented with multiple episodes of blood-stained stools since 7 days of life with no response to elemental formulas. Received multiple platelet transfusions for thrombocytopenia, eczematous rash, more so on the flexures. Endoscopy was suggestive of colitis, and there was no response to steroids. And typically, like when we send the newborn screening, when we send the clinical exam, it was positive for viscot Aldrich, underwent a bone marrow successfully. So in summary, children with Veo Ibd can present with a different phenotype and more severe disease than adults and children, older children. Advances in sequencing technology have allowed for identification of causal gene defects in a subset of patients with Veo Ibd, and identification of these causal variants has radically changed the approach in these children. And it is critical to understand the underlying defect in children with Veo Ibd. So that completes the first part of the talk, and coming to the current treatment approaches. So that is the first part of the talk was predominantly directed towards my general pediatric colleagues so that they do not miss on a child who has recurrent bloody diarrhea, not responding to antibiotics, not responding to elemental formulas. Please suspect Veo Ibd, and especially if there's perianal disease early, it definitely warrants a GI consult. So traditionally, we were taught, I'm sure Ramesh and other gastroenterology colleagues would agree with me, we were taught about the step-up approach. So you start with 5 ASAs, then corticosteroids, immunomodulators, and then go to biologicals. Nowadays, people talk about top-down or step-down approach. And we typically know that these 2 molecules have worked very well over the years. So why has this paradigm shift occurred? Why is the step-down approach important? Because some researchers felt that the natural history of Crohn's, you would have certain treatable conditions like mucosal, but when it becomes a strictures or perforations or penetrative disease, it becomes difficult to treat. Hence, they thought hit early, hit hard. That's why they started off with biologicals and then came down. But then there are many unanswered questions with this top-down approach. How long are we going to continue the biologicals for? No one has a clear-cut answer. Are these biologicals safe for the said mention of, or the said duration of time? That again, no one has an answer. And the most important, does it really alter the natural course of Crohn's, or it just delays the complications? So these questions have to be answered in the future by various RCTs and research. So for us to understand the newer molecules, it's very important to understand the gut immunology. I try to make this animation, but I don't know whether it's going to work or not. So you have the mucosa, submucosa, and the blood vessels. And you can see certain particles coming into the lumen, and the green dendritic cell has caught hold of one of the particles. So it could be a bacterial antigen, it could be a food antigen, and this dendritic cells catch hold of them, either because if there's a problem in the tight junctions, if the tight junctions between the 2 cells are loose, it gives permeability to these cells, or if the Paneth cells creating antimicrobial peptides are not doing their job properly, or for various dysbiotic reasons, you could get one of these antigens held on by a dendritic cell. Dendritic cells are antigen presenting cells. Once these dendritic cells pick up the antigen, they go and present it to a T cell, a naive T cell. So once the naive T cell and the dendritic cell come together, it triggers off a reaction where it comes Tregs, Th1, Th2, all these cells are triggered. And one of those T cells also go and trigger the macrophages. And what does this cause? This causes a problem with a cytokine storm. So you have many cytokines, IL-1, IL-6, IL-12, TNF alpha, all of them being secreted, which you can see like a little green and red stars. So this goes on, and it also gives rise to cytotoxic cells, which can cause damage at that point. But if the cytotoxic cells doesn't end there, so some of these cytokines go down into the blood vessels. And once they go down into the blood vessels, they start making the endothelium express molecules which can adhere to the integrins. And integrins are expressed by neutrophils and lymphocytes. So once these integrins adheres to these yellow molecules in the blood vessel, it gives them permeability from the blood vessels into the submucosa and the mucosa. And finally, they go into the mucosa and damage the mucosa. And that causes all the symptoms of, or all the manifestations of IBD. Then you have newer treatment options. So biologicals and small molecules. So biologicals are basically, why do we call them? Because they're cultured in cell line. They're large molecules, they're expensive, they have to use the parental route, they have long half-life. Small compounds are organic compounds, which are small, less than 900 Daltons, potentially cheaper, oral way of administration, and short half-life. So the newer biologicals, the many anti-TNFs, they're all tongue twisters. There is an anti-IL-12-23, which is where the antigen presenting cell and the T lymphocyte come together. So there is something which can block that. Anti-adhesion molecules like vedolizumab, which can work on the integrins. And you have the new small molecules, which are SMAD7, anti-SMAD7, you have Gi Tract inhibitors. So going back to the anti-TNF. So these have been tried and the results are not very encouraging with golimumab and cetrorelizumab. Anti-adhesion molecules, here there is a little bit of, I wouldn't say hope, and we say that some of these trials have come back saying that the patients are really doing well. So again, you have the dendritic cell. The dendritic cell has a CCR receptor and a CCL25 ligand. So if you block that, further part of the inflammation is taken care of and you do not have further inflammation. So you can have anti-integrin coating. So anti-integrin is the vedolizumab that I mentioned. So you can do that. So once the vedolizumab has coated the anti-integrin, it will not allow the neutrophils to enter into the submucosa and mucosa and cause damage. So it has been nice approved for anti-TNF failures. Anti-cytokine. So here you have a dendritic cell and a T cell. So if a dendritic cell gets in touch with a T cell, it can, again, like I mentioned, it can trigger other T cells, Th1, Th2, T cytotoxic, and Tregs. And based on how much Tregs or T cytotoxic or Th1, Th2 responses are there, the inflammation is decided. So if you have more of Tregs, the inflammation is under control because of IL-10. But if you stimulate more of cytotoxic Th2, then there will be a huge gush of interferons, IL-17s, and that can cause further inflammation. So if you block this part, then the inflammation doesn't progress any further. So ustekinumab antibody blocking IL-12-23 interleukins, and this is also quite promising in theory. Further pediatric studies have to be seen. So small molecules, so you have the SMAD7. So how does this work is, SMAD7 mediates crosstalk between TGF-beta and the intracellular pathways. So if you can block that, the release of IL-1, TNF-alpha, and gamma interferons can be blocked. And then you have the JAK-STAT pathway. So interleukins attach to receptors. Receptors bind to the JAK binds to the activated receptors. JAK then signals the DNA. And if this signal is broken, the DNA cannot give guidance to make more interleukins or more cytokines. So tofacitinib is one of the molecules which modulates signaling of several types of interleukins. The JAK kinases mediate cellular response to many cytokines. Then ozanimod traps lymphocytes in nodes and prevents movement to inflamed tissues. This is another small molecule. So basically, this slide summarizes everything. So you have the anti-TNFs on your right, infliximab, adalimumab. Then you have the anti-integrins in the blood vessels. You have ustekinumab at the IL-12 level and the JAK-STAT molecules. So this is how you can target specific area of the immunopathogenesis to get rid or alleviate the symptoms. Quick word on the mucosa also. So you have a good mucin layer, a healthy mucin layer. So we, as gastroenterologists and pediatricians, advise our patients to take a good fiber diet. And fiber is essential because of the SCFAs, and basically it is the nutrition for the microbes of your gut. So if you don't have fiber, the theory is that the microbes eat into your mucosa. The eat into your mucus layer, and the mucus layer, if it is eaten in, the thickness of the mucus layer decreases, and the access to the lymphoid cells beneath the mucosa is easier. So you can see the normal mucosa where very little bacteria are actually entering it, whereas in the Crohn's and the ulcerative colitis phenotype, there's a lot of bacteria entering into the mucosa. So enhancing the mucosal barrier by PPC. Finally, FMT. FMT has been promising for certain indications, but for IBD, still a lot of research is needed. And basically, what is FMT is you identify a good donor who has a eubiotic bacterial microbiome, and you take that, transfer it into various forms. You can do it in the form of capsule or a liquid, and then deliver it to the donor. And hope that the transplanted microbiota work in the host and confer a health benefit and try and alleviate all the symptoms of IBD. It has been proved very useful for certain indications, but for IBD, not yet. We have some promising results, but it can't be passed down as a recommendation. And in summary, anti-TNF still remains the mainstay of treatment apart from steroids and 5-ASAs. Many novel agents are emerging. Phase 2, phase 3 trials are ongoing. The future still looks bright. Thank you. Hello.
Are you able to hear me?
Yeah, Ramesh.
Thank you, Prashant, for the very informative talk. Lots of factual information about the new molecules. Many of them we haven't used ourselves, apart from the regular infliximab and adalimumab. I think the most important thing for our pediatric colleagues is to when to suspect inflammatory bowel disease, especially so if it's a small child. Then we basically should think of very early onset IBD in those less than 6 years of age. Typical Crohn's and ulcerative colitis still happen in this age, but I think the idea of these monogenetic disorders and the very early onset IBD and the treatment options available, including bone marrow transplant for some of them, are very interesting. But I think the most important breakthrough along with this has been whole exome sequencing, which is available to us over the last 7 to 8 years. And that has actually unraveled and given us so many diseases which we would never have thought of before that we are actually dealing with. Sometimes as a surprise, many of these things come. And for the first time, we'll be dealing with an IL-10 signaling defect, or we had one Carmel-2 deficiency. These are rare things we never think about, but the whole exome sequencing is actually bringing so much of information to us. And some of the times we are able to offer treatments to them based on these genetic diagnoses. So what I would do now is I'll basically invite Dr. Jagdish Menon. Dr. Jagdish, I cannot see your video. Yes, okay. So basically I can see Dr. Jagdish now. So Dr. Jagdish Menon is a pediatric gastroenterologist and hepatologist based at Rela Institute in Chennai. So they are doing quite a lot of liver transplantations and also handling lots of gastrointestinal diseases. So apart from our speakers, Jagdish is going to be an expert panelist for the panel discussion. We basically finished a little late of time. So what we will do is we'll try and be quick with the panel discussion and try to complete as soon as possible. Dr. Sirish, I'm not able to see you on the video. Can you please start your video, please, and also unmute yourself. So the panel discussion, I rather not go through PowerPoint slides, but I will basically go through questions and we can have a straightforward question to answer session where we can all see each other on the panel. So first, I will start off with Jagdish because he's our invited panelist for this. So we basically start off with pediatric acute liver failure. Dr. Siri started off the first session of this morning with pediatric acute liver failure. And he basically presented that 30 to 50% of pediatric acute liver failure can be indeterminate in origin, despite all the investigations and management. And I think with more investigations, we are finding out more of these patients having specific illnesses. What has been our experience in India, Jagdish, from your center as well as in other places? Jagdish, you need to unmute yourself. Unmute yourself, please. Jagdish, unmute yourself, please. You're muted. Jagdish, are you able to hear me? You have to unmute yourself. It's not coming. Hang on a second. We need RSV. Just yes.
Yeah. It's logged in now. It is showing some technical thing there. It's not able to. Sorry. Yeah. Good morning, sir. Good morning, everybody. Yeah. So yeah, I think wonderful discussion, academic discussions on a Sunday, and thank you for the actual invitation. So first of all, talking about statistically, I think the liver failures in kids, I think whatever we see is majority acute viral hepatitis here in India, and the same data we had from Chandigarh also, around 90% was actually in that analysis. It was basically due to hepatitis A, hepatitis E, or sometimes we could see this combined infection with hepatitis A and D. I don't know whether it be the cross antibody response, whatever is happening, or really, if you want to say, we have to see the RNA analysis and see that this is hepatitis A exclusive or hepatitis E exclusive. But there are a fraction of children, I think the data exactly is the same, around 30% to 50%, where the cause of acute liver failure in kids is totally, it actually remains as a mystery. But I think in recent times, we have been doing this genetic analysis, the whole exome sequencing. And we are finding that there are a few monogenic disorders which make them susceptible to acute liver failure, especially the energy cycle defects and the specific mutation named as the NBAS mutation, the neuroblastoma associated sequence. So it has been found to be and increasingly detected, and it is one of the cause for recurrent acute liver failure in kids. So probably as the spectrum of the genetic sequencing and the utility of genetic sequencing is actually expanding, probably we'll be diagnosing more of monogenic acute liver failure. Apart from that, I think after the COVID, I think we had seen a lot of acute hepatitis of unknown origin. I'm certain that in the US and UK, I think we have actually studies which shows that the adenovirus has led to a recent surge of acute liver failures. Here in India also, we have been seeing, in fact, even after transplant, we had 1 or 2 children who had an acute hepatitic, a kind of graft dysfunction. But I think we did the viral panel, which actually includes around 20 viruses, and we couldn't find out a specific reason for them. So I think that is one of the aspects where we have to work more and probably sequence and look into more viruses, which probably leads to this kind of acute liver failure. I think the COVID, after COVID time, there are a lot of hypotheses what they mentioned that there is a super antigenic response to whatever viruses which happens after COVID time, and probably the immune system was in a dormant state because the COVID actually overpowered the other viruses, and subsequently when it came down, it actually is causing issues within the kids. One more thing that we see here, which is not actually very common in West, is the ATT-induced liver failure. I think in the West, probably the drug-induced liver failure are more acetaminophen, as Sir has told actually. But in India, I think the acetaminophen-induced liver failure we see extremely uncommonly. I think one of the inadvertent scenarios where we see it is sometimes the parents can give this paracetamol drops instead of the syrup. The syrup contains 5 ml 125 mg combination, whereas the drops sometimes has is 1 ml 100 mg. So they can sometimes mistake the syrup for drops, and they can give a large volume of drops. So if you give 5 ml of drops, that will go up to 500 mg. And if you give it 6 hourly, it can go into a toxic dose. That is the 1 or 2 real-time scenario where I have seen a paracetamol-induced liver failure. Otherwise, the majority of the causes of drug-induced liver failure I've seen is majority with ATT-induced, drug-induced hepatitis. One more,
Please tell.
One more issue that we sometimes see in kids, rather the adolescents, is the yellow phosphorus poisoning. I'm sure that such a scenario is not seen in the overseas, probably in the West and Europe. I think the main issue is it is either accidental or suicidal. I think we had even a child of around 14-year-old girl who got this medicine. I think on they can get it even online. If you search Amazon now, and if you click rat poisoning, it will be showing it is there, and you can buy it actually online. So these drugs, these agents are actually available, and they use it for even a suicidal thing. The issue with the ratol is your take of liver transplant, I think, is quite tricky in case of ratol-induced liver failure. There are guidelines even from the LTSA which says that if you have an encephalopathy at the time of presentation, or when you don't have a responsive INR after 2 cycles of plasmapheresis, you have to offer a liver transplant. But the problem with this agent is that it can actually get accumulated in the your fat cells in the adipose tissue, and in the post-transplant period. So subsequently, what happens is that when the blood levels drops down, this toxin can get into the blood, and it can cause a recurrence of disease in the graft. So there is one thing that actually is a bit a dicey situation in a ratol-induced acute liver failure. Otherwise, we take the criteria for INR more than 4 as the transplant criteria in India, in fact, except for Wilson disease, where the new Wilson index is the standard criteria for both acute and chronic liver failure in Wilson disease. When it is more than or equal to 11, we usually test them for a liver transplantation.
Very nice. So that was very nice, the way you put it, Jagdish. So many different causes here, still infective causes being the most predominant for us. So now I'll basically ask Dr. Sirish. He mentioned about acute and chronic liver failure. This is also very important because many times they present with us an acute condition, but underlying they may have a chronic liver disease. So even in India also, lots of times they may have a chronic condition. They usually present with an acute presentation of a chronic liver failure. Now, and also this co-infection. We talked about co-infection. We have a lot of dengue and hepatitis A co-infection, typhoid, hepatitis A co-infection. Hepatitis E, initially we thought it's only happening in the Kashmir Valley, but we are seeing lots of hepatitis even in South India. Pockets are there, hepatitis.
Hello. See, we cannot hear you, Dr. Srinivasan. We can't hear you, Dr. Srinivasan.
Sir, any specific concern? I think Dr. Ramesh has to be made co-host.
Right. Okay.
Yeah.
Thank you so much. So
thanks,
I think I'm audible. I'm sorry for the technical hitch.
Yeah. 1 second, sir. I'll just change the I'll just change the setting so that you can. Yeah, I just changed the setting so that you can all speak, unmuting yourself. Please go ahead. Unmute and speak, Ramesh, sir.
I speak. Hello. Hello.
Yes, sir. Now you're audible. Please go ahead.
Now I'm audible. So my question was to Dr. Sirish. I think he is now not there now. Okay. So basically, we normally have a problem. Sometimes we have a little conundrum in our kind of day-to-day practice about sometimes Wilson's disease versus autoimmune hepatitis. Many times we are stuck with that particular thing. Sometimes whether we want to try to give them chelation therapy or sometimes to actually try steroids, sometimes it becomes difficult. And sometimes the coagulation parameters are difficult for us to do a biopsy and prove, and diagnosis sometimes is doubtful because all the tests come borderline. It could be positive for both, that kind of situation. And jugular biopsies are not routinely available for us in many places. Most of the times we depend on percutaneous biopsies. And if our INR goes beyond 1.5 or a platelet count less than 70,000, we are not able to do biopsies at all. And this is one particular conundrum I basically sort of wanted Dr. Sirish's impression on. I think Dr. Sirish is disconnected. So Jagdish, can you sort of take that question, please?
Yeah, yes, sir. Yeah, so basically, I think this diagnostic confusion always exists, especially when they come with acute liver failure or acute on chronic liver failure. I think a few parameters which can give a clue towards Wilson. I think even from the LFT, I think if we start with the LFT, I think low alkaline phosphatase I haven't seen in a patient with autoimmune hepatitis. I think if your alkaline phosphatase is extremely low in the range of 40-50, and there is a disproportionately high bilirubin, I think probably we are dealing with a child with Wilson disease. And one more soft clue that I use for analyzing LFT in a patient with ALF is the uric acid actually. Usually when you have a cell death, like an ALF or other causes, your uric acid will go quite high. But in a given clinical scenario of ALF in Wilson, if you observe, the uric acid will be quite low because they basically lose the uric acid in the renal tubules. So that is starting with the basic LFT. Coming on to the various biochemical parameters, I think the urine copper, there have been studies which actually analyzed ALF of Wilson and non-Wilsonian causes. I think if you see a urine copper that is exceptionally high, that is highly unlikely to happen in non-Wilsonian causes of acute liver failure. So if the baseline urine copper is somewhere more than 200 to 300, I would rather treat the child as a Wilson disease rather than an autoimmune hepatitis. Like one more important aspect that I wanted to just mention is that if at all a child with autoimmune hepatitis comes with hepatic encephalopathy and an INR that is more than 2 to 3, then the response to steroids will be less than 30 to 40%. If the autoimmune hepatitis patient has a borderline INR, child is looking well, INR is around 2, 2.5, we can give steroids, probably 80% of them will respond. But this is what we have seen in clinical practice. When they have an advanced encephalopathy and the INR is quite deranged, then the effect of steroids is quite low in these patients. Yeah.
And one more question is about HLH presenting as a liver failure. So many times HLH presenting as liver failure is once again a condition where many children do not do well, and some children, luckily, they do well and they get better. So many times the secondary HLH are the ones where we have this kind of phenomena. The primary ones where you have genetic mutations, majority of times uniformly they do poorly. What is your impression on that?
HLH, the main issue is, I think they usually present with a multisystemic illness. For example, a dengue patient is coming with encephalopathy, there is hemolysis, and there is coexisting HLH. I think in this case, we have to take a call when or like whether to go ahead with a liver transplant. Usually for HLH, we have learned and we have seen that it is a relative contraindication liver transplant because whatever the cytokine storm happens, it is bound to recur in the transplanted liver. But if there is a scenario, for example, the parents are very categorical, this is going because the other system has got improved. For example, the ARDS improved, the sensorium related to the other aspect of encephalopathy got improved, cardiac status improved, then we have to speak to them openly that the prognosis after liver transplant we are not expecting is not good. So this is in case of a secondary HLH, and the call for transplant is a very soft call. Majority of the cases, we won't actually go out with the liver transplant. Even if you see the literature, there are hardly 1 or 2, I think, case reports of the liver transplant in dengue-associated HLH actually. But in case of an idiopathic or a genetic HLH, it is a contraindication for liver transplant. Whatever the type 1 to type 5 is there, we cannot do a liver transplant. The disease is bound to happen in liver. The only treatment that is available is a bone marrow transplant. But there are actually literature evidence in which the liver failure was going to kill the child. And then they offered a simultaneous bone marrow transplant over a 1 to 2 weeks time. But this requires more evidence and more experience to implement it in the clinical practice actually.
It's a difficult case scenario.
Yeah.
So now we will concentrate on malabsorption. Dr. Pandu has given us a very good and informative talk on malabsorption. Now, can you give a very simple celiac serology guide based on the current sort of approaches, whether a biopsy approach or non-biopsy approach for celiac disease? Because there are some advocates for a non-biopsy approach if you have a TTG more than 200, but most people in India still we follow a biopsy approach. What is your impression on that? You have to unmute yourself, Dr. Pandu. Unmute yourself, please.
Hi, sir. So celiac prevalence is 1% when it's come to the northern part of India. It's also now being increased in the south part of India as well. So celiac diagnosis by the serological test, then followed with the biopsy. This is the current guidelines. However, in 2020, the European Society of Pediatric Gastroenterology have recommended new guidelines where you can diagnose celiac disease without the need for biopsy. In that cases, the TTG should be more than 10 times the upper limit of the normal, and the second serum sample should show positivity for endomysial antibody. In that case, there were earlier recommendation HLA is obligatory. Now HLA application is removed, and you can diagnose celiac disease without biopsy. However, when it's come to the Indian scenario, the most of the children have infestations like giardiasis, cyclospora, and other chronic infestation. So in Indian scenario, still we want to proceed with the biopsy. So celiac serology, a total IgA followed by TTG IgA. And if total IgA is low, then you have to go for IgG for either TTG or endomysial antibody, and then proceed with biopsy. And biopsy look for the characteristic feature, either mass grade 2 or grade 3 is a suggestive of celiac disease.
Yes, so that is actually a change which the Europeans actually tried to make. They wanted to go for a non-biopsy approach by doing the serology and then going for a HLA typing and then doing a second serology to actually sort of confirm what happened on the TTG. But currently the Indian guidelines say we have to do a IgA level total and tissue transglutaminase IgA type ELISA, which basically is non-operator dependent. And then you can actually sort of go for a biopsy if there's any particular doubt to get a histological confirmation. So currently there is no doubt with our Indian scenario about doing the histology as a most important confirmatory marker after the screening serology. Okay. And in this malabsorption, what will be the indications for endoscopy in malabsorption?
Sir, when you are malabsorption, there are many cases. The unexplained growth failure is also one of the indication. Lower GI bleed, along with then serological suggestion elevated CRP, ESR, at the same time elevated fecal calprotein. Then we need a definitive diagnosis. So which are the inflammatory bowel disease and eosinophilic gastroenteritis, even allergic gastroenteritis, and IBD, and other causes of malabsorption like primary intestinal lymphangiectasia. For the diagnosis of lacteal dilatation, we need endoscopy and biopsy. So there are many indications for biopsy and endoscopy in the malabsorption. So it is for some of the disorders, the endoscopy is the line of method of diagnosis confirmation in case of IBDs and celiac disease.
Yeah. Now I will ask Dr. Chandrasekharam. This one, subacute appendicitis and chronic appendicitis. Sometimes sir is actually on the phone. So, Dr. Chandrasekharam, sir, kindly unmute yourself, sir. 2 or 3 questions, then we'll wind up for the day.
Yeah, sure, sir.
Subacute and the chronic appendicitis. Sometimes we see the subacute appendicitis. We do have some children who come to us with chronic abdominal pain. And sometimes what has happened is they have been diagnosed with appendicitis at some stage, but later on there has been no problem. This subacute and chronic appendicitis is a cross of chronic abdominal pain. How frequently do you see in your surgical practice, and does an appendicectomy cure their problem?
Yeah, I think I'm not sure if there is these terms are clinically very specific terms. So that's the problem. So, they have some kind of pain, they have some vague tenderness in the right iliac fossa. An ultrasound shows a 6 millimeter appendix. The radiologist says it's subacute appendicitis. And most commonly, the sign the radiologist says is non-compressible structure. But as I have shared in my talk, this is a very, very non-specific sign. But the radiologist always seems to rely on this sign. So I think we go more by the clinical criteria. And coming to the aspect of chronic pain abdomen, which usually more than 3 months is considered to be chronic pain abdomen. And some of these children have all tests normal, and they finally end up with a diagnostic laparoscopy. Surprisingly or interestingly, many of these children may not have a major pathology even on diagnostic laparoscopy. But somehow an appendicectomy seems to cure most of these children of their pain. We do not, at least the reports say so. Now, we do not know why, but if the index of suspicion is high, especially the pain in the right iliac fossa, there is interestingly something called as appendicular colic. Now, again, we do not know how specific this diagnosis is, but this pain is a colicky pain typically occurring in the right iliac fossa, aggravated with food intake. So these are children, some of these children who present with chronic pain abdomen have this kind of a component. So in some of them, if you do a laparoscopy and you do an appendicectomy, of course, when you don't find any other pathology, they seem to be cured of their chronic pain. Whether it is, kind of a placebo effect of having undergone a surgery, we do not know. But some of these children, when we do a laparoscopy, we find some adhesions of the appendix and the cecum to the abdominal wall. If you find adhesions, then you release the adhesions and do an appendicectomy. They are definitely likely to benefit from your surgery. But this is a very gray area, and I would be very, very skeptical to do a diagnostic laparoscopy for a subacute or a chronic appendicitis kind of a situation.
And you did touch upon the fact about CECT. You said contrast enhanced CT. You're not particularly keen about doing contrast enhanced CT. But most of the times where we are in a dodgy territory, we do not know whether this appendicular inflammation is severe or not. We do subject them to a contrast enhanced CT. But obviously the radiation risks are there, like what you actually pointed out. But there will be some information gathered from that to try and make our plans more clear as to where we want to go.
No, you're right. You're right. I mean, we need not do CT in every suspected appendicitis, but it's definitely a useful investigation when you are not sure.
Yes, sir. And one more thing was about additional obstruction. Many times post-surgical patients do come to us with the subacute obstruction or little bit of bile tinge vomiting or bilious vomiting. Many times we do conservative management and they actually settle and they actually go home. Most of the times we sort of them nil by mouth and they get an enema and they evacuate from the bottom and they are fine. So additional obstruction, obviously if it is severe enough, then obviously intervention. Otherwise, most of the times conservative management may be helpful.
Absolutely.
And also you touched upon an early diagnosis of volvulus, about there being relative paucity of gas in the top end. And obviously if the volvulus is very proximal, then you told about how the left, all the small bowel is seen on the right side, following the torsion in the volvulus. So that was actually very handy. So thank you, sir.
I think the single most important thing that we should not miss is a malrotation with volvulus. I think that is something where irreversible bowel damage can be prevented.
Thank you so much, sir. And my one final question before we actually close, because we finished late in time, was about the IBD management, because Prashant seems to have left the forum. About the top-down management. In your current practice, Dr. Jagdish, are we doing a top-down management in your particular practice in Chennai, or we are basically doing a traditional step-up practice? Are you using biologicals right at the beginning to sort of hit hard on the disease, or how is it?
So majority of the cases, I think we are going by the conventional step-up approach only until we have a very solid evidence that was discussed in the last talk also. Unless they have a quite severe, for example, the Crohn's disease activity index is quite high. They have some fistulizing disease. And if they have severe growth retardation and they have got some abscesses. So these are the indications where sometimes we'll start them upfront on biologicals. Otherwise, 90% of the patient, we are starting with a step-up approach only, unless we get evidence.
Yeah. And about the use of the very early onset IBD, I think we are all learning at this point in time. All of us are seeing more diseases. We have seen some IL-10 signaling defects, and we have had one particular thing called a Carmin deficiency. So the Veo Ibd is actually going on, becoming more, and we are getting more information from the genetic studies. And bone marrow transplant also, we are only building our experience now gradually. I think even worldwide, the experience for bone marrow transplant Veo Ibd is actually increasing slowly. So
that's true, sir. Yeah, that's true. If I can just mention for a minute, I think we had this patient with viscous Aldrich who presented to basically the GE unit with an inflammatory bowel disease. The endoscopy was very typically looking like Crohn's. That this child actually had thrombocytopenia rather than thrombocytosis of Crohn's.
So did he have the skin rash, the eczematous skin rash?
Yeah. So then when we started evaluating, I think we then found out that it was due to a VASC gene mutation. And then we offered a bone marrow transplant. And within, I think we repeated the colonoscopy over a span of 8 weeks, and the disease has completely disappeared. And the biopsy was actually showing a resolution of colitis. So that is how early they can have even a resolution of after a bone marrow transplantation.
Absolutely. Yeah. Thank you so much, Dr. Jagdish, for being part of this Sunday morning webinar. It has been great having all the speakers here. So basically, sort of, we'll now draw it to a close so that we can all do our Sunday chores. Thank you so much. Thank you. Bye-bye.
Thank you.
I'll pass it on to our Iaptcb group and for the vote of thanks. Thank you so much. Bye-bye. Bhaskar sir, are you available? think he has muted himself. So what we'll do, I'll basically sort of, on behalf of IAPTCB, I will ask for this meeting will draw it to a close. And thank you so much for sharing your valuable 3 hours on a Sunday morning for the pediatricians in Hyderabad. Thank you and have a good day.